On the outside, you might just see a happy child playing. A child excited to explore the world. You might not see a child with cystic fibrosis until you start to see its symptoms as they progress over time. But if you could see inside, you would see the damage taking place. Even before you see the symptoms progress and become visible on the outside. Don't wait to see cystic fibrosis. On the outside.
Καλημέρα σε όλους.
Good morning, one and all. We'd like to thank you for being here with us, and a very good morning to those of you who are attending on the line. My name is Anna Spinu. I'd like to welcome you to our conference, Cystic Fibrosis Preparing for the Future, which is organized by the Hellenic Cystic Fibrosis Association. Today we also celebrate the World Day for People with Disabilities. We are celebrating. So this conference is under the auspices of the municipality of Athens, the Eurodis Rare Disease Europe, and CF Europe, Cystic Fibrosis Europe. So every year our association organizes this conference, and we'll have speakers, our doctors, specialized experts on the disease, healthcare professionals who are going to inform us about the latest developments regarding the disease and will give us instructions. We'll talk about transplants. At the end of each session, you will be able to put your questions. Those of you on the internet, you can send us. Now, our conference is being live streamed on YouTube and the website of our own association. So please use the functions of the internet to put your questions. So today we celebrate our 40 years of presence. We had planned to provide to offer a commemorative plate to Mr. Adam. Unfortunately, he wasn't able to attend. And we'll also have, at the end of our conference, a presentation of the first interactive children's book for cystic fibrosis, which is an initiative of our association for children with cystic fibrosis, for carers, and anyone who would like to know more about cystic fibrosis. So we'll start. And we'll start with the brief addresses by the officials. Good morning. My name is Konstantina Yanaki. I'm a parent of 8-year-old Dargiris suffering from cystic fibrosis. We'd like to welcome those of you attending online. Now we'll start with the brief addresses by our officials. Anna, would you like to start? Yes? Okay. So our first brief address is by the Minister for Health, Mr. Michalis Christochoidis. Unfortunately, he wasn't able to attend. However, he has sent us a written message that we are going to read, supporting through time the patients with cystic fibrosis.
Good day, dear participants. Unfortunately, prior obligations do not allow me to attend. It is a great pleasure and honor, however, to greet the conference organized by the Pan-Hellenic Association of Cystic Fibrosis. Such conferences provide the opportunity to highlight and project in a scientific and sound way important aspects and dimensions of this serious disease. a disease that already from childhood prevents important daily activities and often deprives people of life itself. In this daily and constant struggle for survive, patients and their families are not alone. Specialized and qualified scientists and health professionals are near them, guiding them, taking care of them, keeping them alive. The state, the government needs to provide to health professionals the qualifications and tools required to support them in their difficult task, especially in terms of providing qualitative services to patients. The Ministry for Health does this, and I pledge to you that we will keep on doing it. We monitor developments and the new knowledge, and we pledge to take all measures and decisions as necessary to ensure every innovative and revolutionary treatment to patients. Also, all tools and mediums that will support the work of health professionals. At the center is patients and human life. No planning, no political choice is effective unless it takes into account the needs and the problems that we know are there. However, there are also solutions that I would like to listen to and discuss with scientists and with patients' associations. The patients themselves and their families, known from first-hand experience the problems, and every public debate should include them. Thank you for this honorary invitation. I wish you every success in the proceedings of this conference, but also in any other initiative that you assume to foster the visibility of cystic fibrosis and to support patients. Let us of us work together to create a future of health and quality of life. Thank you. The Minister for Health, Michalis Chrysochoidis. We thank the Minister, and we continue our cooperation with the Ministry for Health through all these years. It has been very helpful, and we will move on to the next address. CEO Eurodis, Plant Diseases Europe, Jan Lacam. He is with us remotely.
Jan, how are you?
Thank you. I am very well. Thank you very much, Anna, for your invitation this morning.
Oh, thank you so much, and the floor is yours.
Thank you. I'd like first to express the warmest wishes for the 40th anniversary of the Hellenic Cystic Fibrosis Association, and to congratulate you and all the Hellenic Cystic Fibrosis Association and its volunteers in the last decades for the great work that you've been doing. You managed to do successful advisory advocacy to change what it means to live with cystic fibrosis in Greece, to improve the quality of life of the persons living with cystic fibrosis and their families, and to improve access to diagnostic, to treatment, to care, to lung transplants. It's also important that Rare Disease Greece, which now exists in Greece, gathers together all the rare disease patient groups existing in Greece. So it's very important that the Hellenic Cystic Fibrosis Association, as you are, is a member of Rare Disease Greece and take an active part in order to develop a national strategy and to be part of the European and global processes on rare diseases. This will improve the situation of persons living with cystic fibrosis in Greece, because then you're not alone, but you can count on each other and represent a critical mass in Greece and a political voice. I'd like to share with you a few reflections, but before, I'd like to start by saying that I'm the Chief Executive Officer and founder of Eurodes, Rare Disease Europe, and in fact, I am one of yours because I'm a father of a young adult affected by cystic fibrosis. I have 3 daughters, and the oldest one, Colleen, has cystic fibrosis. She's now 33 years. She had a double lung transplant 5 years ago, and she's currently waiting for a kidney transplant. One of the family members will give her a kidney. And she has also diabetes and many other comorbidities, as I am sure many of you have. And exactly like in the video that we just heard, You could not see it. If you was coming in the room where you are, you will see just a young, beautiful woman who is a lawyer working in international affairs. And she's a hard worker. She works 4 days a week, but she works hard and she has a good social life. And she's able to say that she's happy in spite of all the huge care that she has to take every day, every week, every month, like all of you. For that reason, I have been also, like some of you, have been a volunteer in the French Cystic Fibrosis Association, VANC pour la mucoviscidose, and I was the vice president for research for almost a decade. Before, with my wife, we decided to have a third child, and part of the negotiation was to stop to be a volunteer in an association in addition to work in another association. But today, I still continue once in a while to help this French association. Recently, we had a seminar on the long-term strategy to assess the impact of the new treatment and what it means in terms of new challenges to identify where the focus of the attention of the association should be, and also how to prepare for bigger changes as maybe there will be less volunteers, less attention for cystic fibrosis. I'd like to mention here one thing that I can see at the European level, and that's important for you, is that there is a lot of discussion at the European level about what is called the unmet medical needs, to prioritize the development of medicines, to prioritize research, to prioritize allocation of money for the diseases where there is not yet treatments. And I am sure that for you, as for me, I will consider cystic fibrosis as one of these areas of unmet medical needs, because even though there is important treatments that now have been approved in the last years, we see that we are far from having a satisfactory solution, let's say, for all patients. There is the patients who don't have mutations for which there is treatment, but even when you're taking the tree therapy currently, you can still continue to develop difficulties. You can go at the hospital. You can be stopped from going to work. So we're far from having solved everything, and we still don't have a cure. But however, that's for us. That's how we see it as clinicians, as parents, as patients ourselves. But whole society around us, including scientific, including policymakers, they think the problem is solved for cystic fibrosis and that we need to move to the next disease. So we need to be very careful and to advocate very strongly to express what are the current realities of living with cystic fibrosis, even with the treatments, and what are the solutions, the pathways needed for the next years, so that there is unmet health and social needs, which are recognized. With that, I'd like to highlight that cystic fibrosis is one of the diseases at the European and even global level, but particularly at the European level, where there has been huge gains. I don't know exactly, but more or less, when you look at the observatory, we can consider that we have gained 6 months of life every year in the last 30 years. That's huge. It's huge. And the perspective for the child we were born 30 years ago, 20 years ago, and the perspective of being born today with cystic fibrosis are obviously very different. And this was thanks, first and foremost, to the organization of healthcare, the multidisciplinary consultation, the specialization of cystic fibrosis clinics, the networking of doctors between themselves at the national level and now at the European level, the sharing of good practices in diagnostic and care. So bringing the knowledge together and applying the existing knowledge, but also generating new knowledge on how to care for persons living with cystic fibrosis or children living with cystic fibrosis. And there is a model here which can apply for other rare diseases. And it is first this improvement on the diagnostic and the newborn screening, on the care, the management, the day-to-day management, and the strategies of autonomy of patients, therapeutic education, physical therapy at home, IV cure of antibiotics at home, which have been able to gain these 6 months of life expectancy until there is now the transformative treatments, which hopefully are helping us to gain much more, maybe 9 months, 10 months, 12 months per year, until maybe we will live a normal life expectancy with the disease or with a cure. Now, to conclude, I would like to highlight how your action for cystic fibrosis in Greece is linked to action at the European level in cystic fibrosis, but also what you do in Greece with the other rare diseases is linked to a bigger movement and policy at the European level on rare diseases. You are connected to the CF Europe, Cystic Fibrosis Europe, which is your European federation. And once in a while, I also do some volunteer work for them to help them to create, for instance, a community advisory board on cystic fibrosis to engage with the different companies for the development of their treatments, but also to create the roundtable of companies in order to attract funding to the Cystic Fibrosis Europe and be able to develop more activities. And there is huge challenges, obviously, on access to care, simply not the diagnostic, the newborn screening and the care in Europe at large. There is still huge inequalities, obviously, across EU, but also even more so across Europe at large. And that's an area to focus on. But it's important to continue to influence from that platform at European level the future development of medicines, but also the organization of healthcare. As the number of lung transplants, for instance, will decrease for cystic fibrosis, we need to ask ourselves how we should be organized at the European level. And can we still maintain lung transplant unit for cystic fibrosis in every country in Europe? Or should we organize ourselves in a more rational way so that there is some teams which are doing regular procedures and can deliver a quality transplant where you go? So we'll have many challenges of this sort. We certainly also have challenges ahead when new therapies, maybe gene therapy, maybe CRISPR, whatever the strategy that will work. But when there will be the curative treatment coming in, it will be an even more difficult debate to have access to it in Greece, like in the other countries. We will have to justify what is the gain for the healthcare system financially to pay for that higher cost treatment compared to the existing cost of treatment today, compared to the absence of school or absence from work, or the absence of the parents from work, and etc. And you have the European Reference Network for the lung rare diseases, of which cystic fibrosis is part, and that's a wonderful asset. We will have soon also the clinical research networks for rare diseases, and there will be one, obviously, around the lung, and that's important to follow. And all of them, all these networks are sharing progressively the same standard, the full interoperability of data. We're still far from that, because the problem is to collect the right data. And that's another area where an association like yours is important, to make sure that your clinicians in the hospital have the right resources to be supported, to collect the data and enter the data in the registries in order to be able to share. We can have the best standard of the world, the best interoperability. If we don't collect quality data at the clinic where the doctors and the patients are, we are not transforming the care. And last but not least, is just to say that now we are entering a new phase of policy development for rare diseases. You may know that in 2019, a text was adopted by the United Nations General Assembly for universal health coverage, which is a beautiful objective. It's an utopia somehow, but it's important. All the member states in the world have engaged in saying, we will provide universal health coverage to certain population. And together, all the patient groups, we succeeded to obtain that rare diseases are part of that universal health coverage, which means that any person with a rare disease in the world is supposed, probably long term, but to have the right services and the right financial coverage for their needs. But that has started in many countries, obviously in Europe since a long time, in many countries around the world also, and in an increasing number. And I can tell you, I can see progress every month in that direction, which is very encouraging. And that commitment of the United Nations was done again with all member states this year in September in a second political declaration on universal health coverage. We have also gained in 2021 a United Nations resolution to recognize the challenges of the 300 million persons living with a rare disease and their families. And this is a more detailed document about the needs and about the type of actions that member states should engage and that the different agencies of the UN system will engage. And we are now already en route in working on a WHO, World Health Organization resolution on rare diseases, which we hope to be adopted in 2025, and 2 years later to adopt a global action plan on rare diseases, looking toward 2040. So, and that here there will be objective goals. And I insist on that because I think that for Greece, that's important. We're trying to obtain goals at the global level, global goals in a European action plan for rare diseases, which we hope after the European Parliament election and the new Commission, it will be adopted. There will be a European action plan for rare disease in Europe and a new generation of national plan and strategies in every country. I know you recently adopted a strategy in Greece because I was part of some of your conferences and listening to the colleagues working on that. And that's great, that's fantastic. But your next generation of plan needs to have goals and goals aligned with these European and global goals. And that's great because it helps to federate our actions. It helps to have much more efficiency to improve the survival, the quality of life of living with a rare disease, the inclusion of society, the potential to live or full potential, and to live with independent autonomy. Thank you very much. I wish you a great conference. I saw your program. I was particularly pleased by the fact that you're also looking at what's happening in the United States and you're covering the different challenges of the moment across. And I really praise your efforts. And although I cannot follow, obviously, presentations in Greek, my spirit will be with you during all that day. And I wish you a very fruitful conference. Thank you.
Dear Jan, I would like to personally thank you. First of all, thank you for your warm wishes about our anniversary of the association. Thank you for sharing your story with CF as a member of our CF family. And first of all, thank you for your contributions. All these years, you are the founder of Eurordis. You have done an excellent job. And I feel very lucky to be a new member of the board of Eurordis, of this great team. Thank you, Jan, for everything. Thank you very much.
Thank you, Anna. We're happy to have you. Thank you again for the invitation today. Thank you.
Ο κύριος Γιάν Λεκάμ, πολύ σημαντικό που...
Mr. Jan Lekam, it's very important that he participated today. I wish we could have him physically here. Now we give the floor to Mr. Philip Watt, the president of CF Europe. Unfortunately, for technical reasons, he cannot be connected. So now Mrs. Kabordini Theano sent us a written address. If you have the slide, you can put it up. She's the manager of EOP. I'm reading to you the message of EOP's manager. Dear ladies and gentlemen, unrelenting supporters to improve care of cystic fibrosis, I'd like to thank you for this invitation. This meeting is a forum for exchanging views and practices that will contribute to the improvement of life of those suffering from cystic fibrosis and their families. As you know, when there is transparency and a map road, any insecurity is done away with. At AOP, our mission is clear: to facilitate and ensure access to treatment and services. We pledge to availability, access, and affordability of drugs and services associated with cystic fibrosis. You know that AOP actively supports the access of sufferers to modern treatments for cystic fibrosis. We have the pleasure to announce that delivery of drugs at home includes the people suffering from cystic fibrosis. These are some first steps, and I believe that each and every one of you has an important role to play in further actions and steps. This conference symbolizes a collective effort to promote cooperation for a hopeful future. We have a demanding way in front of us. I'd like to wish you every success in the proceedings of your conference. Hopefully, we will listen to proposals that will contribute to change for the best. We thank the manager of AOP warmly.
Ευχαριστούμε την κυρία Καρποδίνη και να πω ότι πριν περίπου 10 μέρες...
Thank you, Ms. Carpodine. 10 days ago, we were invited and had a meeting by the manager of ALB in order to receive more information on the home delivery of treatment. So we will be starting, I think, early December. We are waiting for the ministerial decision to be signed, and we'll let you know about the procedure. It's a very simple procedure. The doctors will need to select during the prescription process the box that will pertain to home delivery. So we'll begin with this home delivery with cystic fibrosis drugs. Now we move on to Ms. Kanaka Christina, who is the president of the Child Institute and a professor of pediatrics, endocrinology with the National University of Athens. Yes, thank you very much. Thank you very much for the invitation. As you said, as director of the first clinic of pediatrics of the University of Athens in Hagia Sophia Hospital, we do hospitalize children with cystic fibrosis, and we don't know. Okay, I turned the microphone on. Thank you very much. So, good morning once again. As Ms. Pino said, I'd like to thank her for her invitation. I am a professor of pediatrics and pediatric endocrinology and director of the first pediatric clinic of the University of Athens at the Hagia Sophia Children's Hospital. You all know about it. So those of you in Athens, it's the largest children's hospital of the country and of the Balkans. And in fact, we are in the same campus with the Department for Cystic Fibrosis. And on top of that, we have the Child Health Institute. And in the central building, we have the University Pediatric Clinic. So we have an interaction between the patients and our doctors and myself. As a professor of pediatric endocrinology, we treat our children with cystic fibrosis as soon as we have diabetes. Now, let me point out that already my own training and education was in Germany, and in particular in Switzerland, where we had a lot of cases and many different families that we had to help with members with cystic fibrosis. And it's with real pleasure that we see that the treatments have evolved. I'm here under my capacity as president of the Child Health Institute to announce to you that this year we have started in a pilot project a neonatal broadened screening test that includes cystic fibrosis in it. I've brought a presentation with me. Anyway, I want to be needing that. I will give you the presentation.
Ωραία, εδώ είσαι.
Συμβαίνουν αυτά στα ζωντανά. Περιμένουμε λίγο να δούμε. Είναι σημαντικό να δούμε και την παρουσίαση της κυρίας.
It's important for us to be able to see the presentation by Ms. Kanaga in order to receive that information. Now, with the screening, the neonatal screening, we'll have the diagnosis of neonates from the first days of life, because it is important for these children to start treatment as early as possible.
Συγγνώμη για την καθυστέρηση.
I do apologize for this delay, but indeed, my relationship with the Institute is going back many years ago because I was responsible for children with congenital hypothyroidism. Since 2015, I was the deputy president, and the president was Mr. Dudunakis. Already since that time, we tried to have incorporated in neonatal screening the cystic fibrosis, and as of 2020, I am the president of the Child Health Institute, and indeed we have been able to make a reality what is really important for timely diagnosis. Regarding the national program for screening of neonates, you know that as soon as a child is born, on its 4th day, we get the heel prick test, a few drops of blood that are sent to the Child Health Institute. So centrally, we have measurements both for congenital hypothyroidism as well as galactosuria, phenylketonuria, and as of September 2022, there has been the information of the Public Health Experts Committee and the Deputy Minister for Health, and they have approved of this pilot screening program that will be broadened. So you see the neonatal screening in Greece. It will no longer cover only the 4 diseases it used to cover in 1979, but in a pilot project we have added amino acid diseases, oxyurias, beta oxidation of fatty acids, and cystic fibrosis, which, well, the screening works really well, and you know that this was a gap we had to fill in our country. This pilot project will run until 2025, until we are able to show the positive results and until it's fully incorporated in neonatal screening. We see that in 2010, there were already states that used neonatal screening. This expanded in 2020, and we are really proud today to see it in our country. I won't be talking about the substrates of neonatal screening. As you can understand, as I have already mentioned, and in the same building, in the Doxiadis building. Well, Doxiadis was a really famous pediatrician who used to have faith in preventive pediatric medicine, and he was the one who organized the Child Health Institute. So on the top floor, we have the Child Health Institute, and on the ground floor, we have the cystic fibrosis floor. So as soon as we have a positive sample, there is a open contact and there is also the sweat test, and in the campus we have the molecular confirmation of the test. As you can understand, the molecular confirmation does not belong to the initial screening, but there is a constant communication between the members, not only in the Attica region. but also elsewhere in Thessaloniki and throughout Greece. Cystic fibrosis screening has started as a pilot project 4 months earlier. It's working, and we have a very good communication between the treating physicians and the family. So I'll move on to the data here, because I want you to know that there is this possibility for early intervention. I see Mr. Dudunakis showing up, yes. And let us remember that the Child Health Institute, amongst the main works, with the help of the Ministry of Health, in general covers all these diseases whose early detection is of particular importance vis-à-vis the early onset of treatment. Because if we delay the onset of treatment, we have issues with all such diseases, because there might be irreversible changes. So we'd like to warmly thank the Ministry of Health for listening to our own needs and accepting to incorporate the neonatal screening in order to make it a reality and to be able to set diagnosis early enough, avoiding late diagnosis. Mr. Giginoudis is the coordinating director of the program for the national neonatal screening plan, and it pertains to the entire country, whereas the heart and soul of this program is also Dr. Dimitris Platis, who implements this, who is a member of this screening program in Europe. And you can see a whole team of technicians, technologists, etc. The aim being for early diagnosis and treatment. So with these few words, I'd like to thank you, and allow me to point out once again that as a member of the National Committee for Rare Diseases and as a member of the working group of the Ministry of Health for Rare Diseases, our aim is for all rare diseases to be treated in Greece and to be given timely diagnosis and treatment. So I'd like to congratulate your association, and I bid you a very good morning. It goes without saying that our cooperation will be continuous. Thank you.
Mrs. Kanaka, thank you very much. We know that you are very busy, so the mere fact that you found time to came here, not only you came here, but you made a presentation, you prepared a presentation. I want the best for our children. It is important. We are in Europe. I am responsible for rare endocrinological diseases in Europe. And it is important to understand that Greece not only does not lag behind, but we need to cooperate for the best of our patients. You mentioned Eurordis. I recently was appointed to the board. The people do an excellent work there. It is very important to have research and cooperation. Last year, I was in the Czech Republic, and truly we were discussing about that with the representatives of Eurordis. The aim is that the national local ERMs become hubs for all national hospitals, and this in its turn should be fed back into Europe. ERM are European reference networks, specialized centers that have the knowledge and give specialized care to patients. So it's very important to have this interaction. Thank you warmly for being here today. All the best. We wish you all the best. After Mrs. Kanaka, we will give the floor to a very important speaker. We have a great pleasure of having this person with us. Dimitris Zografopoulos is the GPO Data Protection Officer is the title in English, from the Ministry for Health. He will be attending virtually. Thank you very much for waiting, Mr. Zografopoulos. We're looking forward to listening to what you have to tell us. Thank you very much for coming, for attending. Good day. I'll try to speak slowly for the interpreters' sake. Thank you very much. I'm very sorry for not being able to attend in person, but I am at Ioannina. There is a conference here on drugs, so I had to participate virtually. I'd like to thank the Pan-Hellenic Association and Mrs. Spinu personally for the invitation. This is a very significant invitation, and all the more so due to your flattering reference. You said that I make a valuable contribution for the registry of patients with cystic fibrosis. Thank you. I think that the patients themselves have a central role to play, and they have placed their existence under the microscope. I just offered my personal work. I'm very proud for the creation of the registry. A landmark is 6:10 a.m., 8 March 2020. I had finished the draft of the ministerial decision and sent it to all the members of the scientific committee with very few changes. That draft became the final document on establishing the registry of cystic fibrosis. I'd like to thank warmly the scientific team of the registry, which had given me very clear directions about how to draft the decision, and especially the then representative of the Pan-Hellenic Association, Mr. Dimitris Koutoupidis, an endless source of inspiration for us to move forward and properly with setting up the registry. Let me underline some important points about the registry of cystic fibrosis in Greece. My own job is to have a clear assurance on behalf of the Ministry for Health that everything takes place properly, by the book. And I can guarantee that. I know that there have been many reservations and a lot of anxiety in patients for the processing of their personal data. I can guarantee that everything happens according to the fundamental requirements of processing as imposed by the European legislation. The way the ministerial decision was drafted, and that's the importance of my know-how, that's where I come in. We should not forget that cystic fibrosis is perhaps the most frequent rare disease that we record, but it's still a rare disease. The peculiarity of this ministerial decision is that it allows a full registration of the parameters, not only for statistical registration, but mostly with a view to providing medical services and providing the opportunity of access to innovative treatments. This is very important, and this is an endowment, if you like, not only for cystic fibrosis patients, but for all rare disease sufferers. I feel that any registry on rare diseases should be based on the notion of the disease or the group of diseases. We could talk about respiratory diseases if we had not a cystic fibrosis registry. Such a registry should include all those parameters that are crucial and important for the provision of medical services. You've heard Mr. Lecam speaking about the importance of data, not only for rare diseases in general, but in particular for cystic fibrosis. One of the big legal and scientific peculiarities of this registry is that it allows interconnection with the European registry of cystic fibrosis patients. What does this mean? It means a flow of data to and fro. We can send information of patients that have consented to the transmission of their personal data to the European Registry of Patients with Cystic Fibrosis, and we may receive data from the registry, and this is very important for the patients because we have to keep case histories. So we can make cross-checks for the accuracy of data and compared to those kept at the corresponding European registry. I don't want to tire you with legal details. I know that I was invited only to give a short address. Of course, if during the event there are questions from the participants or from the audience, I am at the disposal of the organizing committee. You can just call me and we will organize a connection. I'd like to thank you warmly once again for the invitation. I'd like to wish to each one of you all the best. Be healthy first and foremost. I assure you that I will keep on working non-stop with a view to the proper operation of the National Registry of Patients Suffering of Cystic Fibrosis. I'd like to thank you from the bottom of my heart. Mr. Zografopoulos, we truly thank you. We have Mr. Tsanakas and Mr. Hadjiagor, Mr. Damadia, Mrs. Manika, all the physicians, the doctor, Mr. Paraschakis as well, who were members of the scientific committee for the National Registry of Cystic Fibrosis. A very significant tool for the community, for our doctors, for the patients, that gives us useful information. Thank you very much for your contribution, for all your work in this process. This is one of the first registries of patients that were created in Greece, and the rest are beginning to form. Yesterday, the Ministry for Health announced in the infographics the data from our registry. Perhaps Mrs. Hadjiagor could say a few things later on about the registry, and Mr. Tsanakas. Thank you, Mr. Zografopoulos. Thank you very much. Be well. Take care.
Και θα περάσουμε τώρα στον επόμενο χαιρετισμό.
Now we move on to our next address. Mr. Tsanakas is here with us. So Mr. Tsanakas Ioannis is a professor of pediatrics. He has been working for years in the cystic fibrosis department at the Hippocrates Hospital in Thessaloniki, and he is responsible for the scientific committee of the National Registry for Cystic Fibrosis and the scientific coordinator of Hospital at Home program for children with cystic fibrosis. He's going to share with us very interesting data. Dear friends, thank you very much for your invitation. We hold specific relations, special relations with Stelios Dodonakis, who was the supporter of this whole effort, and Mr. Adam, and I'm really glad to see him. I think that they can't hear you. Yes, okay. So, I'm really glad to have him with us. We are always enthusiastic about his calmness, his patience, and he passed the torch on to us to continue. Now, first and foremost, I'd like to congratulate the association that held the event amidst the Christmas environment that inspired me while we arrived here in the Christmas village. Because as you know, Christmas is all about hope. And what we come to confirm today here is hope on cystic fibrosis. And now you know about the new drugs. Our great joy is that this hope today will be confirmed with figures up till yesterday, we would be working strenuously to give data and to compare Greek patients' condition with the European patients' condition. And you'll see with surprise that we are faring equally well as the European cystic fibrosis patients. This is a leaflet published yesterday by the ministry with statistics, and we owe many thanks to Mr. Zografopoulos, who was a previous speaker, who has been the DBO, and he is there to safeguard the interests of patients to avoid their exposure and their data exposure for to avoid exploitation. So as you can understand, Mr. Zografopoulos works for you, and he's almost invisible. He protects and safeguards all our personal data in order for us to be able to be protected. Another thing I'd like to point out is that I'm also glad because I have passed into a group taking care of patients with severe problems. This is the hospital at home group. This was started out with patients with cystic fibrosis because people had to be hospitalized for 14 days for IV treatment, and this was really, really displeasing because we had children having to be hospitalized. Now we decided gradually to avoid the hospitalization, and we extended this to other severe disease patients. And today we have had this opportunity given by the ministry to provide hospital services at home with hospital doctors, physiotherapists, etc. And if in case of deterioration, they are able to be hospitalized. So this is your own achievement, because this is where we started from this idea. The last thing I'd like to share with you is another very, very hopeful message. The fact that our children today and patients with cystic fibrosis, as you see through the mathematical and statistical data, have no reason whatsoever to be jealous of the European statistics. Of course, the new treatments have led to us forgetting many days hospitalization of patients. We are really glad because patients with cystic fibrosis can be treated as other patients as well. And this is what brings us joy. Now, I'm really, really glad to see that we too participate in this fight. You as parents are helping your children, and we are we are there to help you and your children, but we get the joy from you that things will move on and they'll be better. Thank you.
Thank you, Mr. Tsanakas, for taking a plane and coming here to be with us in person. You have offered a great lot to patients with cystic fibrosis all these years, and although you are now an emeritus professor, a retired professor, you still go on doing everything you can for the best of these patients. Let us now give the floor to the next speaker. Through the internet, this is Mr. Loukidis Stylianos, President of the Greek Lung Society. We have a we mutually esteem each other. Lung medicine is closely connected to cystic fibrosis. We're glad to have you. First of all, good morning to everybody. I apologized for not being able to attend. Today I have to be at the Attikon Hospital. What I had to tell you Well, let me begin by saying, and in the last 2 days, the European Lung Society organized an event on cystic fibrosis in adults. As a director of the scientific program of the European Lung Society, this was a personal bet for me. It was organized in Milan with physical participation and remote participation. Everyone warned me against it. It's not going to be successful, they told me. In the end, there were 300 participants, an excellent discussion. And this shows that scientific information has to become very intensive. Cystic fibrosis is now a disease of adults for a great number of years now, which is great joy for us. The Greek Lung Society continues for the 5th consecutive year to finance from its income a scholarship for the cystic fibrosis ward at Sismanoglio Hospital, not only in order to help Mrs. Diamandea, but in order to help all these people acquire skills for the 2nd consecutive year based on a decision that we made last year, and this is the 2nd year that we've been implementing it. We give a clinical scholarship at the Hospital of Papa Nikolaou in Thessaloniki, and as a testimonial to the intention of the society to have 2 dynamic wards in hospitals, to preserve them. We also took an initiative that we will expand to other agencies and bodies. For adult pneumonologists have received the first letters from our society, and shortly we'll send letters to pediatricians and to the transplant unit. So with the new year, we have received positive answers. We will meet together, and 2014 will be a year dedicated to an effort to look at what will happen with adults with cystic fibrosis, and we will institute a cooperation with the ministry. This is a very important initiative. There are very few members of staff. We need to approach and mainly train people with skills in cystic fibrosis. This is a personal bet, a personal wager. I am a director of the the lung ward for 3 years, and I want to expand these efforts with other bodies and agencies. I wish the best to everybody, lots of health, have a happy holiday, and I think that all these things that we have in mind and we want to put in practice, hopefully they will be implemented for the best of our patients. Thank you very much for the honor of inviting me to take part to this conference. Thank you.
Mr. Loukidis, we really thank you for finding the time to join us today. We know that you are really busy. Congratulations on the conference in Milan, because ultimately cystic fibrosis pertains to many people. And now, as you talked about the adult center, well, this is a very important matter. We, as an association, try to contribute towards this direction because adult units are really understaffed. We have 300 patients and only one doctor said there. So you can understand that it is important for the ministry to examine it and to listen to these needs, to reinforce the units, to have specialized pulmonologists that will be supporting us as doctors. And so as for patients to be able to take the care and receive the care that they deserve. So thank you very much, Mr. Loukidis, for your contribution. Thank you. Thank you, too. Now, Mr. Paraskakis, I'm going to introduce Mr. Paraskakis. He is the chairman of the Hellenic Society, Pediatric Respiratory Society. Thank you very much for coming here. Now, thank you. It is a great honor for me to be here in the event on cystic fibrosis, preparing for the future, representing the Pediatric Respiratory Society. We come in contact with the the courageous children suffering from cystic fibrosis and their carers and families. And we see that indeed the messages from research and from science in the past few years are really hopeful. And it seems that the future of these children and the joys for their family will be many. And this makes us really glad, because I have to admit that the pediatric community is particularly proud for this development, since pediatricians have taken a lethal, a fatal disease, and nowadays we are faced with adults who have a much better prognosis. We have secured a much better quality of life for these children, and a smaller burden for their families. This to us is particularly important. So doctors such as Mr. Adam, Mr. Dodonakis, etc., really actually help the children and families with children with cystic fibrosis, and they will definitely be glad, because we have added hope. We are really, really close to new scientific successes. Now, pediatric pulmonologists are always close to children with cystic fibrosis with high qualifications and education and training. So we keep on promising that we'll stand by the children. Thank you.
Thank you, Mr. Paraschakis, for your beautiful words and for being with us and for having come from so far away, the island of Crete, to be here with us today. That was the end of greetings and addresses, and we will now move on to a very moving part of this event. Today, or not today, this year, we celebrate, as you know, 40 years from our foundation in 1883. All of us were babies compared to where we are today. The association started from its inspirator, Mr. Georgios Adam. It was our first pediatrician, for those of us in Athens who worked at the Children's Hospital, the ward of cystic fibrosis. Adam took our young parents by the hand and told them, let's make an association. It was a very difficult period. When I was born in 1981, my parents were told that I was not going to live. association going. We were small children at the time. We could not help at the time. After 20 years, we became of age. We were the first patients. I remember Yannis Orfanos, Mariliana. We were adult patients at the time when Mr. Dudunakis, I see him behind Marilena. We were young children. We came to your clinic and you took care of us, and Mr. Tsanakas too. We invited Mr. Adam Georgios, who gave the inspiration for the association. Unfortunately, yesterday he called me. Unfortunately, he was unable to attend and he cannot receive the honorary plaque personally. Nevertheless, he asked me to convey his affection. He remembered us by names, every one of us. He remembers all his patients. He told me that he never forgets us. He holds us in his heart. And he promised that when he would get better, I will go there personally and deliver the honorary plaque to his, hand it over to him. So we don't have Mr. Adam with him. We have the plaque, but I want us to stand up. I want Mr. Dudunakis to come here and receive it, and our doctors, and make a beautiful photo. The former boards and the parents take a picture. I'd like to thank all of you because it is thanks to you that we are here today and move into the future.
Κύριε Ντουντουνάκη, θέλετε λίγο να μιλήσετε πριν βγάλουμε...
Mr. Dudunakis, can you say a few words before we take this picture, this photograph? Say a few words. This association was on the occasion of Mr. Adam hosting the European conference of cystic fibration, and he had to have a parents association in order to demonstrate that Greece was not a delayed, backward state of the Orient, but a nation of the West. So we wanted to be modern, and we did it. And today we have a disease which is treatable, at least for 80% of the patients. And we have happy hearts. You have grown up. You are smiling. And we are smiling at you with pleasure. Thank you very much. Let us have a picture here with the plaque. Please, all board members, all doctors, and Mr. Dudunakis, please join me.
Και μετά από τη...
And following this emotional part, we move on to the scientific part of our conference, and we will move to the first session, which has to do with cystic fibrosis complications. Now we'll call upon Ms. Diamandea from Cystic Fibrosis Centers, please. Ms. Diamandea. So you can stand there, and we'd like to call upon the rest of the speakers, Ms. Manika, Ms. Hadjiagoru, and Ms. Petroghilou, who is not arrived yet. I'll ask them to join us in the panel. Okay, so Ms. Diamandea's presentation. She's going to talk to us about the recent data from the triple combination effect in cystic fibrosis lung function in adults. Thank you very much. If we're ready. Thank you. Good morning from me as well. I'd like to warmly thank you for the invitation. My topic is recent data on the action of the triple combination in the lung disease in adults. So I'll be as brief as possible, but it will take more than 10 minutes. I'm going to share with you the data from recent research and together with the patients' registries, and I'll share with you some data pertaining to the patients from our own center. We all know that this triple combination restores, in fact, the functionality of the pathological protein at a high rate, more than 40%. In our patients. In Europe, right now, there's approval for patients with at least one mutation, Delta F508. In the States, it has been approved for even for those who don't have this mutation. And we have access to this treatment, and we'd like to thank the ministry for that, for giving us the opportunity to take good care of our patients. We know that at least 10% of functional protein is adequate in order to avoid the manifestation of cystic fibrosis symptoms. So we all are aware of the spectacular results of this drug in the respiratory function of such patients, and how it does away with exacerbations, severe exacerbations that need to be hospitalized. Now I'll talk about the action of the effect, rather, of the drug on the rate of the FEV. Now, in this study, which was published in 2022, there were two groups of patients. One with patients who participated in the approval studies of the group of the drug, and in the other team, the other group, we had patients from the American registry with the same mutations who were not on this combination. These are the demographics of patients. And what we see here, is there a pointer somewhere? Okay, so what we see at the upper blue line is that the drug, in fact, stabilizes the respiratory function. Whereas now for patients who do not take the treatment, there is a impairment of the functional of the respiratory function. The same goes in both groups, and this is in fact the first drug that shows stability of the respiratory function, at least in the depth of 2 years. So far, the high Vicaftor and the double combinations would reduce the impairment. But nowadays we see stability. Now, the second study, again, uses those patients who had participated in the approval studies and compares them with themselves 5 years before the administration of the drug and 5 years after. And now we have the data so far of the first 2 years. These data pertain to respiratory function, the exacerbations, the hospitalizations due to exacerbations, pathogens, culture, and potential implications on the liver. 60% of patients were on the treatment. And you see the 5 years before the treatment, there was an impairment of the respiratory function, a progressive impairment, and as a result, we see at the time where they started receiving the treatment, already in the first year there was an increase of 8.2 in the respiratory function, which was stabilized and reached 8.9% as compared to the pre-treatment period. We see here what was the case with the microbes. The vertical line shows when the drug was administered and how there was a lower prevalence of pathogens, both for Staphylococcus as well as for Aspergillus. It was reduced, but it wasn't eradicated fully. We see what happened with exacerbations and hospitalizations. Second year, we had a 79% reduction of exacerbations and 44% reduction of hospitalizations. And we see that there was an 85% reduction of lung transplantation risk. And 72% reduction of the death risk. Regarding complications such as upper airways, polyps, pararhinosinusitis, diabetes, stress and depression, and hypertension. There seem to be no changes in the 2 years from the onset of the drug. And with regard to the effect on liver, there was only an increase of bilirubin, and this changed. Now I'll show you data from our own patients of 2 years following the onset of treatment, and they come from the Greek registry. These are 86 patients who had a median age of 28 and FEV1 52% before onset, and we measured the respiratory function, then annual rates, and the IV administration days 1 year prior to the onset of treatment and 2 years after. So we see the characteristics of patients: 13 years on average of hospitalization 1 year before the onset, and here we see how much increased was the BMI in the first year, and it was stabilized later on. We see respiratory function plus 8.5% benefit in respiratory function in the first year and 10% in the second year. And in fact, the second year we had 0 hospitalizations as of the onset of the treatment. Therefore, this triple combination had a significant improvement to the respiratory function and nutrition of patients, and led to the significant reduction of exacerbations that would call for IV treatment. The efficacy of the drug remained stable in 2 years' time. Here are data from the European registry pertaining to 3 years, 2011, 2016, and 2021. You can see the age groups of patients, and you can see that Pseudomonas was reduced in all these age groups progressively throughout these years. There has been a reduction of chronic Pseudomonas infection in all age groups of cystic fibrosis patients. Here are data from the American registry And you can see back in 2011, where we had the introduction of ivacaftor, and in 2019, the triple combination, how the frequency of the prevalence of the microbe is reduced. In the pandemic years, of course, it was reasonable for it to be reduced, but it was even more reduced after the onset of treatment. These are data from the Spanish Pulmonology Society, pertaining to 114 patients with 30 months follow-up. The vertical line signifies the onset of the treatment. You can see Pseudomonas, Staphylococcus, and Achromobacter are quite reduced after the onset of treatment, and Pseudomonas at some point is close to zero. So given data from the American registry, we have a reduction of the positive cultures percentage following the onset of treatment. We have these two studies researching what's going on with culture and microbes in cystic fibrosis following the onset of triple combination. This is a PROMISE study for patients above 6 years of age and begin with children under 6 years old. This is the first study where they studied sputum and culture, and we see that there is a reduced prevalence, but it is not eradicated fully. We have a stabilization in 6 months' time, and in this year's conference they mentioned that the results remain stable for 1 year. However, despite the fact that Pseudomonas is not identified in culture, it is identified still in molecular techniques. On the left we see patient 8, 17, 43, etc. In blue you can see the positive Pseudomonas cultures. In yellow you see negative Pseudomonas cultures. And in the second panel we see that there are patients who were negative in culture. From blue they turn to yellow. In molecular techniques, however, we were able to trace Pseudomonas in some of them. So it's not fully eradicated. It might be reduced. The burden is reduced, but the organism is there. We knew that already from all the data with ivacaftor. In the first year, we have a lowering of the density of the Pseudomonas, and then it reappears. And now, following the after the respiratory function and the pathogens, they also studied structural characteristics, having a CT scan for patients in 1 year from the onset of the treatment. There was a 42% reduction of positive culture for Pseudomonas and Staphylococcus, and here we see the data pertaining to structural changes in the lung. In 53 patients, we had less bronchial wall thickening, in 7 less bronchiectasis, in 11 lower, we had lower hyperinflation, etc. You can see the CT scans of patients before and after treatment, the improvement. This is yet another study which is really recent and was in Ireland and in the UK, and it pertains to imaging data as well. This study, aside from the improvement in lung clearance index, showed also an improvement of scores in the CT scan. However, we observed that what was improved was inflammatory lesions in the lung and not structural lesions. In fact, where there were structural characteristics such as bronchiectasis, there was no improvement. These are permanent lesions. Only the inflammation characteristics were improved. Now, I'll share with you what happened with our own patients, what happened with Pseudomonas. We're talking about these 86 patients I mentioned earlier who have completed 2 years for treatment. We see, first and foremost, that following the onset of treatment, 35 out of these 86, 40.7% of them had no huffing, and there were cultures in pharyngeal smears. So Before they started the treatment, 87% had Pseudomonas. The first year, this percentage dropped to 78%, and the second year to 71%. And the status of these patients changed in 12.8% of patients. We are interested in seeing what happens with atypical mycobacteria. This is another study from Israel with the inclusion of the patients with at least one positive culture in the past 2 years and were on the drug for at least 1 year. In 9 out of these 15 patients, of whom 7 had abscessus, which was a very aggressive atypical mycobacteria, there was eradication, and at the same time there was improvement of their function. We're also interested in checking what happens with more aggravated patients with a less than 40% FEV1, because in general in the studies we had 40 to 90% FEV1 patients. So to see what happens with the patients with more aggravated function. So this is a study from 47 cystic fibrosis centers in France, and 9 of which were transplant centers, with 331 patients above 12 years of age with severe pulmonary disease with less than 40% FEV1 who were in the transplant list or were to be included in one in the next quarter. And they were followed up for 1 year. Out of these 331 patients, 45, or rather 65, correct the speaker, were lung transplant candidates. 17 were already on transplant list, 48 were considered for lung transplantation. So what came out at the end of this treatment after 1 year? Only 2 patients underwent lung transplantation, 2 remained on the transplant list, and out of the 65, 61 were no longer meeting transplantation criteria. As we see in this diagram, in the black color, you can see that during the months there was a reduction of the percentage of patients who were candidates to transplant. Their FEV1 was improved, and the same benefit was seen in patients with lower FEV1 initially. You see progressively there was a reduction of oxygen use at home and reduction of the BiPAP. I'll share with you our own data for our own patients who were lung transplant candidates. We followed them up, or rather we included patients who had severely aggravated FEV1 and who had completed at least 2 years of administration. We checked what happened in the first month and in 2 years' time. 13 such patients, out of whom 4 were in the list and 9 were to be included in the list. These are the genotypes. We see how there was improvement in month 1 of the BMI. The FEV1 was improved in the first month, and then it was stabilized, and there were less exacerbations. There were no hospitalizations for these patients because these are severe exacerbations with a need for IV treatment. No patient was on oxygen at home, and no one was included in the transplant list after the onset of the drug in these 2 last years. Again, data for the respiratory function from the registry we see for the several age groups and how this was reduced in the 20 years. So 56% was the average for respiratory function, and now it reaches 80%. Less exacerbations, severe exacerbations with the need of IV antibiotics in 2018. This is from the American registry. 43% of adults would need IV treatment, and this dropped to 15% in 2022, respectively for children, 23% turned to 10%. Again, other data from the American registry, you see how the exacerbations are lowered. What happens with inhaled antibiotics after the onset of the triple combination? We see here some clinical signs that are really important. The inhaled antibiotics are prescribed in patients with a triple combination for this respiratory infection that still remains, and the patients are recommended to continue this treatment. Clinicians need to decide about the cost benefit in case they decide to stop this. And despite the fact that these are highly effective drugs, they do not normalize lung physiology, they don't stop inflammation, and they don't resolve chronic lung damage such as bronchiectasis. In fact, so far there have been no studies justifying the discontinuation of inhaled antibiotics, and we need to have more research. Now we move on to lung transplants. There was a reduction in lung transplants. These are our data. In the blue bar as of 2014 and onwards, we have the referrals, and in yellow in red we have transplantation. So there is no list of us in the list. There's no patient of us in a list. Survival was increased. The median survival 36 years in 2002, 56 years in 2022. The median means that at least half of the patients will reach that age. And this can also be seen here in the American registry. At the same time, a drop in mortality rates. The American registry on the left and the European registry on the right. 58% of patients in the US and 54% of patients in Europe are adults. The green bar corresponds to adults. The yellow bar corresponds to children. You can see the increasing number of adults. And this is a projection model that was presented in last year's American conference that shows that by 2040, the number of adult patients with cystic fibrosis will be 70%, whereas the number of pediatric patients will remain approximately stable. Conclusion. From the data so far, we see that the triple combination has a significant benefit for the FEV1 of patients of at least 12 years of age. The benefit continues to remain stable in 2 years' time. Patients with a severe pulmonary disease have similar benefits regarding their respiratory functions as patients who have been included in the approval studies, and a significant percentage of those who had been in a transplant list have been taken off the list. Despite the improvement of the FEV1, the inflammation and infection remain. And the triple combination is a disease-modifying treatment. Thank you.
Mrs. Diamanta, all this is very striking. But please sit here. Keep your questions for the end. I myself have many questions. Remote viewers can also send their questions. The next speaker is Mrs. Perlepe Garifallia Irini from the new clinic at Larissa, together with Mrs. Carecci. They are doing very good work. She's going to talk about aspergillus. Aspergillus is a matter of concern for many patients. She's going to talk about it. Good day, Mrs. Perlepe. Thank you for being with us. We are not receiving sound. Yes, now we can hear you. I apologize sincerely for being unable to attend. I was on call and I could not change that. Thank you very much for the opportunity of including me. It's very interesting conference. Mrs. Carecci and myself Of course, we only assist, we have an assisting role only, but we are eager to help people in our remit so that they can have someone to call when they need help. Okay, I will start my presentation and I will try to summarize as much as I can. Are you looking at my slides? Yes, we do. I will try to the best of my abilities to summarize the information from the literature in view of respiratory disease caused by Aspergillus. I will start with some research information about this fungus. This fungus has a very distinctive morphology that allows it to attack the host. It has a basic part, texture, and another part, a conidiophore, which contains the conidia that through breathing reach the respiratory system of cystic fibrosis patients. And they are trapped in this mucus, which is a feature of the disease. This process is called colonization. Under the effect of various parameters, I'm going to talk about them, the immunological system is being activated with free radicals. The disease moves to deeper epithelial layers, and we have these textures. This is the typical cellular and histological image. Aspergillus should be a priority for patients with cystic fibrosis. There is the physiopathology behind this. The malfunctioning of CFTR induces an inflammatory response which favors hyperinflammatory responses in Aspergillus and cause this aspergillosis. We know from in vitro studies that mice with a poor CFTR function have a poor clearance of this fungus in the lungs, and the typical mucus is a very good environment for Aspergillus colonization. In addition to the damage caused by the CFTR, the high incidence of bacterial infection is another risk factor. That's why the chronic use of antibiotics for fungal infections increases colonization from fungi. You see the use of inhalers creates colonization from bacteria. You see the percentages. Candida and Aspergillus. In this big literature review of 6,000 patients, you see that the constant isolation of Aspergillus is found in 9.6%, and here risk factors associated with isolation are the inhaled antibiotics, macrolides, and corticosteroids through the nose. What does Aspergillus causes? One can say that the less infectious situations are the mere colonization incidents, a sensitization. I will explain the difference. And then disease which calls for treatment, allergic aspergillosis, aspergilloma, bronchitis associated with Aspergillus, or invasive infiltration disease, which is rarer. For colonization, information varies a lot. Some studies speak about 5 to 78%, 3.9 to 42% elsewhere. It is the strain of the Aspergillus. Aspergillus fumigatus is the most frequently found strain, and we have to be vigilant because it is something that we have to check for. There are various laboratory tests that can help us classify patients in one of the categories I mentioned. A patient who is merely colonized will have a mere isolation identification in a sample from the upper respiratory. A sensitized patient might have increased levels of total IgE or specific IgE antibodies for Aspergillus. In aspergillosis, we also have a very high IgE combined with positive antibodies for IgE and IgC for Aspergillus, and also another product of the fungus that can be found in sputum and in FAM and in bronchitis or infiltration disease. We have increased IgE, specific IgE, and the last one. The big question is whether this mere colonization tell us something, if it has any clinical significance. It seems in the international literature to have conflictual findings. There are merely colonized patients with lower pulmonary function, increased risk for pseudomonas, increased risk for exacerbations, but there are other studies which have not associated Aspergillus colonization with malfunctioning. It is very hard for the clinical physician to associate knowledge about the forms of the disease with the clinical findings and findings from imaging, MRIs mostly. But clinicians should always be suspicious. In addition to CT scan, patients should explain their clinical systems, coughing, sputum, dyspnea, or spitting blood. These are symptoms that are increased in patients with bronchitis or bronchial aspergillosis, perhaps combined with respiratory impairment. As to findings from CT scans for aspergilloma, imaging techniques are very significant. The typical image is diagnostic, a ball, in fact, a fungal ball within a pre-existing cavity for infiltration disease and bronchitis. Usually we have nodules, there is bronchiectasis, alveolar shading, whereas for aspergillosis we have central bronchiectasias with a hyperdense material. There are these typical images. You see here to the left-hand side the typical ball or orb with air above and around, above in patients with aspergilloma. Lower left-hand side, nodules with thick walls in the bronchi in Aspergillus-associated bronchitis, and to the right-hand side you see the very typical image of bronchiectasis with this content, which is hyperdense. In bronchial aspergilloma, you need to do all the routine tests and treatment. There are criteria. We need to have two criteria: positive findings, increased IgE for aspergillosis with very high levels of IgE, as I mentioned earlier, and combination with two of the following elements: IgG antigens for Aspergillus, imaging, typical imaging, or increase of eosinophils over 500. For bronchitis, we have elements from patients without cystic fibrosis and guidelines on the documentation of the disease. There should be cellular material or bioptic material that is typical. We need to have a detection of the fungus in association with textures and laboratory findings. The disease may be probable or certain depending on information from the host, clinical information, or lab criteria. Especially for cystic fibrosis and bronchitis and positive disease, we need to consider this when we have two cultures with isolation of Aspergillus, when we have new symptoms and impairment of respiratory function, when we have divergences. This is very important with comorbidities for which patients take treatment but don't respond to treatment. When the imaging image is compatible and when there is response to fungal treatment, this is a powerful sign. Other minor criteria include lab tests, lab criteria that we might have. And we move to another important factor extensively found in the literature. There seems to be an increased and frequent coexistence with Pseudomonas. This is a vast slide, I'm sorry, but you see that there are very mechanisms by which the two microbes compete with each other, and through this competition, they coexist in a host. And we care about that because there are observation studies that note exacerbation when we have coexistence of Aspergillus and Pseudomonas. This is a co-colonization, reduced FEV1, more frequent hospitalization, more frequent exacerbations, increased use of antimicrobial treatment. From the UK, a study references with lower body mass. We have to keep this in mind. Now, treatment choices. The big question is to distinguish, for the doctor to distinguish based on the available information, if it is colonization or if we have active infection. However, there are studies that consider whether merely colonized patients should retrieve treatment. We have conflictual evidence here. There are treatments like this randomized study. It showed no effect for primary or secondary signs, exacerbations, or IV antibiotics and pulmonary impairment. Another study in Ireland showed that treatment can reduce the mediators of inflammation associated with the disease and perhaps improve results in the CT scan. But it seems what we should keep in mind is that we have conflictual evidence. For pulmonary aspergillosis, there are clear instructions, corticosteroids, clearly, a lot of adjunctive treatment, supplementary treatment. Usually the dose for the acute phase and exacerbation is 1.5 milligram per kilogram, and then a gradual reduction depending on IgE levels, which show response to treatment. As to antifungal, their role is questioned clearly. Some studies show that by reducing the fungal load, there are positive effects, but antibiotics, the use of antibiotics is inconclusive. For bronchitis and infiltrating disease, the first treatment line and choice is corticonazole or liposomal amphotericin beta in highly refractive areas. You see the dosages and a systemic treatment. For patients who are colonized and get a lung transplant, preventive voriconazole is recommended. It has been associated with reduction of pulmonary disease. We know that azoles are well tolerated, but there are effects associated with hepatotoxicity or changes in vision or neurological disorders or increased sensitivity. And something else? Voriconazole and traconazole are activators of C3A, and we have serious problems in co-administration with CF modulators. We have to be careful about the dosage, and other factors are also involved. We have various choices where feasible. Treatment should be administered in patients with documented disease, as many problems may arise. What seems to be gaining ground in international literature is that azole treatments have a place. We know that amphotericin beta, much more than azoles, they have a pharmacokinetic properties that allow them to remain for longer intervals and therapeutical windows in patients, and we can have a good and effective treatment. There is indication as a prophylaxis in lung transplant. From these patients who have most data, we can have the measurement of the various levels and decide whether they're healing. There doesn't seem to be a lot of penetration in systemic circulation, and this is the interesting point because they will have lower risks with co-treatment, and many studies deal with therapy for hypertasic infection, where there is a question mark. And I will conclude with this message. Although Aspergillus has a great span of action, like other microbes which are traced in cystic fibrosis patients, we know that modifier treatments have reduced colonization in these patients, and this is encouraging. Thank you very much.
So, within this framework, and due to this difference between the official indication of the drug in the States and Europe, this year we had the publication of a very interesting study that was conducted in France, a palliative program for people without delta F508 who were above 12 years old and who were with an advanced disease, FEVF under 40%, or probably in the list for transplant. So this combination was administered for 4 to 6 weeks, and it was evaluated by a committee consisting of at least 3 experts in cystic fibrosis patients, 84 people, 16 children, 68 adults with advanced disease, of whom 23 had at least one mutation for which they would have been given the triple combination if they were in the States. FEV1 32%, low BMI 19.3 kilograms, 27 people suffering from diabetes, and quite a few of them had oxygen at home or non-invasive ventilation at home, which goes to show the severity of the disease. So in 4 to 6 weeks' time, 45 people out of these 89, that is 54%, considered that they had a favorable response. Of them, 23 people had at least one mutation approved in the US by the FDA, and 39 people did not respond. So you can see the responders vis-a-vis the sweat test here on the right, and on the left, the FEV1 response rates. Regarding those who responded, 45 people responded after 4 to 6 weeks of treatment. There was a reduction in chlorium in sweat by 30 millimole, improvement in respiratory function and weight, improvement of symptoms, and people who were on the list were off the list. Out of these 45 people, 22 patients without the approved by the FDA mutations, there was again seen a reduction in the chlorium of sweat, an improvement overall. What was observed was that those patients with the N1303K mutation seemed to respond, 8 such patients. This is the list, the table of patients who did not carry these mutations that were approved by the FDA, and the first 8 had this N1303K mutation. The characteristics of those who were non-responders, 39 non-responders without any difference in sweat chlorium or respiratory function or weight. Some of them had improved symptoms. However, this was not considered adequate reason for a response evaluation. So this study concludes that a significant part of people with cystic fibrosis and advanced disease might suffer from rare mutations that have not had approval in Europe, and they might be able to show improvement. Those with mutations that have been approved by the FDA, plus those with the N1303K mutation. Within this framework, there is also a publication in a small series of 8 patients with this particular mutation, 2 homozygotes and 6 heterozygotes, who were given this triple combination for 8 weeks, and they showed improvement in respiratory function and weight. And a last study on that specific subject showed that we can get nasal epithelium cells. This is easy to get from cystic fibrosis patients, and then cultivate them with the CFTR modulators. And we can see the response at the cellular level of the CFTR function. This was done for 39 patients, and as you can see, each bar shows at the molecular level the response of the CFTR. So the higher the bar, the better the response of the CFTR to modulators. Now, those in dark blue show those with mutations that have been approved by the FDA. Therefore, we see that there is a great heterogeneity vis-a-vis the response, but those mutations that have been approved by the FDA show the greater response. What is really important here is that we can predict from the cellular response the improvement of the respiratory function and the sweat test when such patients are given the drug. And I will conclude showing you this case, the data of this patient. I have been approved to share. So one of our patients, 34 years old, with the N1303K mutation with this advanced disease in the imaging exams, and we've started him on triple combination in June. You can see the before and after data. Increased weight by 4 kilos, improved FEV1, 106%, and there are no exacerbations. This was the main problem with regard to this patient. He had 4 exacerbations in the past year, whereas in the last 5 months he's doing really well. Now there is yet another patient with the same mutation who has just started getting the triple combination, seems to respond, and we have administered the drug in another 2 patients with very rare mutations, and we don't know whether this has a positive response or not. Although it's quite early, it seems that one is a non-responder and the other one shows an improvement of symptoms and a reduction of insulin needed. Thank you.
Ευχαριστούμε, κυρία Μανίκα.
Thank you, Mrs. Manika. Many questions to you afterwards. Now, Mrs. Fotoulaki Maria, she's connected virtually from the University of Thessaloniki. She's going to talk about the impact of innovative treatments on nutrition and on the digestive system. Do we have Mrs. Fotoulaki online? She hasn't connected yet. Let's go on to the next speaker, and as soon as she is connected, also virtually, Mrs. Eleni Papadaki from Hospital Papanikolaou is going to talk about sleep disorders in adult patients with cystic fibrosis. Is our connection with Mrs. Papadaki on?
Ωραία, είμαστε έτοιμοι λοιπόν να συνδεθούμε με την κυρία Παπαδάκη από τη Θεσσαλονίκη.
We are ready to connect to Mrs. Papadaki from Thessaloniki. Good day. Thank you very much for this honorary invitation. Can you hear me? We can hear you, but we do not see you. Hopefully, we will see you in a moment.
Αυτά είναι με τα διαδικτυακά.
Well, that's the problem with online connections, but technology make it possible nevertheless. Welcome. Hello, thank you very much for the invitation. Congratulations for the organization. I will talk about sleep disorders in patients with cystic fibrosis, adults, and I will rely on a study that we conducted in Papanikolaou Hospital with cystic fibrosis patients. What we know is that although cystic fibration patients have similar sleep architecture with normal people, non-patients, however, cystic fibrosis patients complain about their sleep. From a study between patients and non-patients, SF patients had sleepiness during the day more, and their quality sleep affected negatively their quality of life according to the relevant scores. And the most frequent disorder is hysticonemia. We were based on questionnaires mainly, and there is an association of sleep disorders with respiratory function and other clinical parameters. All patients were submitted to spirometric measurement. There were questionnaires, the Kerem questionnaire about coughing, and the 3 questionnaires for sleep quality, Pittsburgh, ESS, and AIS. A few words about questionnaires. The Kerem questionnaire is the only questionnaire for cough studied in cystic fibrosis patients. It quantifies coughing during the day and during the night and has a score from 1 to 4. 4 corresponds to more intensive coughing. Sleep evaluation questionnaires, in general use, the most frequent ones. The Pittsburgh is the most widely used questionnaire to appraise sleep quality. It is comprised of 19 questions about 7 categories of problems, and there is a score over 5 indicates poor quality for sleep. Epworth scale, daily somnolence, positivity limit 11. Then we have the Athens with 6 as a border. Now the effects of this the findings of the study. 18 patients participated. The mean age was 30.17 years. BMI 26.36, F1% 58.93. We hope you have time to read through these. It was found that the mean value in the Epworth score was 6.61. This is increased somnolence during the day at the upper levels. 2 out of 2 scores had over 11. The mean score in Pittsburgh was 0.6, which is 5 is the highest normal limit. 3 had a pathological over 5, and 22% had a score exceeding 5, so pathological. And the AIS questionnaire, the Athens questionnaire, the mean was 4.39. 8 out of 33.3% had a score, a pathological score. And of these 6 patients, 4 had mild insomnia, 1 moderate insomnia, and 1 serious insomnia. 7 out of 18 patients, 38.8%, had pathological scores in at least 1 questionnaire. 1 patient had pathological scores in all 3 questionnaires, and 2 had at the same time pathological findings in 2 questionnaires. As regards the association of Pittsburgh questionnaire with clinical parameters, it was found a statistically negative association between the Pittsburgh questionnaire and oxygen saturation. Patients with lower saturation rates had worse sleep quality. Now, as to the association of the coughing questionnaire and the other questionnaires, it was found that the intensity and frequency of coughing during the night is associated with the Pittsburgh questionnaires and the Athens insomnia scale in a statistically significant way. So patients with worse cough have worse sleep quality. As regards chronic infection from Pseudomonas, there is a statistically significant difference between patients with or without chronic infection as to intensity and frequency of coughing during the night. The chronic patients have higher scores in this respect, i.e. more coughing. In the conclusions of this study, 8 out of 37 patients, 38.8%, a very great amount, had pathological scores in at least 1 questionnaire for sleep. The mean value in Pittsburgh was 5, which indicates sleep disorders. 16.6% of patients had pathological scores in Pittsburgh, 22% in the upper normal range. The mean average in EPCOF was 16.1, which means increased somnolence during the day in the upper normal range. 2 out of 18 patients had pathological scores in Epworth questionnaire. 6 out of 18 patients, 33.3%, manifested insomnia, mild, moderate, or severe. Patients with low saturation in a resting pace in rest have worse sleep quality, according to Pittsburgh. The severity is associated with insomnia. You can read. You can read the findings. The interpreters cannot make it in time. Generally, sleep disorders in cystic fibrosis are frequently underdiagnosed comorbidity. These three questionnaires are useful tools to evaluate sleep quality in patients with cystic fibrosis, just as in the general population. They can easily be included in patient appraisal in the annual control as a screening method. Patients with pathological scores should be referred for registration. Thank you for your attention.
Ευχαριστούμε, κυρία Παπαδάκη.
Thank you, Ms. Papadaki. Will you be staying with us for the questions in the end? Yes. Okay. I don't know, Ms. Paketulaki, is she ready? Otherwise, we can move on to Ms. Petrohilou, who is here. Now, Ms. Petrohilou from the Children's Hospital, she's going to talk to us about the more recent antibiotic treatments for cystic fibrosis. Good afternoon. Thank you very much for the invitation. I'd like to congratulate you for having organized this. It is very nice to see you again. Now, I'll be very brief. These are the recent antimicrobial advances in cystic fibrosis. So we'll talk about the available ones because there are some new data. Then we are going to move on to some new antibiotics that will be coming, but also other methods of handling the infections because, as you know, resistance to antibiotics is a big problem, not only for cystic fibrosis, but for all diseases globally. So since we are running out of antibiotics and we have resilient microbes, then we try to find new ways to deal with infections. We'll be talking about inhaled antibiotics mainly because these are treatments that were able to greatly improve the quality of life of patients. These are inhaled, they can be administered at home, they work against chronic infections and they maintain a very low load burden that allows us to reduce the symptoms, and they are also useful in the eradication of Pseudomonas, the one that is of interest in cystic fibrosis. So this allowed us to reduce hospitalizations as compared to the past, since we were using the combination of inhaled antibiotics with but also antibiotics or on their own. Starting from a very old drug, colimicin, which is available for inhalation. We used to use the powder, which is for IV, and the nebulizer use, and currently they are starting in order to have it approved by the FDA. There is a much more specific powder for nebulizers, but there's also the dry powder device with dry powder capsules. It's something like the inhalants of the Ireland type, etc., in order to allow for a very quick inhalation twice every day, which lasts less than 2 minutes. Many times with a nebulizer, the children need to use the nebulizer up to a quarter of an hour, which leads to difficulties in quality of life. Tombramycin, a second substance used. This is aminoglycoside, and we know that it's really active for Pseudomonas. It does have an action on other microbes such as Staphylococcus, but we mainly use it for Pseudomonas. And we used in the past the IV preparation through the nebulizer. However, then we had a special solution made for nebulizers, which is both for the eradication as well as for the chronic treatment of Pseudomonas. And we can also find it in dry powder devices in the past few years, allowing us to reduce the treatment time, 4 capsules inhaled in the morning and the same at night. So, although there is no resistance to tobramycin, inhaled tobramycin, since there are strains of Pseudomonas that are resistant to the drug, we study in order to add yet another substance which is called EDTA calcium, which is going to improve its efficacy. And we consider that it's going to be really useful for chronic infections because it does break the biomembranes, the biofilm. This resembles a membrane made up by microbes. So it's like a plexus, a grid, whereby microbes become more resistant to antibiotics. They join forces and therefore they are much more strong, not allowing antibiotics to enter the mucus. Therefore they become much more resistant. And this is considered that it's going to be breaking the biofilms and biomembranes, and thus the drug will reach the microbes easier, in an easy way. Astronam, also in circulation, again for Pseudomonas, for the time being only through a nebulizer, the appropriate dosing 3 times a day. There are certain studies speaking about 2 twice a day. But 3 is what is recommended. This is also helpful for children showing tobramycin resistance or not helped by colistin. And there are also data on chronic infection with Pseudomonas, as well as for eradication. Amikacin. The IV preparation has been used for years for the treatment of atypical mycobacteria, but it can also be administered in case of Pseudomonas. Atypical mycobacteria are very small microbes resembling the tuberculosis microbe, but they're a bit different vis-a-vis cystic fibrosis. These are atypical, and they are particularly well, it takes a lot of combination treatment, so we use amikacin. Already in the States, we have the preparation of which is particular to nebulizers, and in fact, we're going to have it here soon. We had clinical trials in Greece as well on amikacin, and it seems to be quite effective. Moving on to recent advances. I'm going to talk to you about gallium, a heavy metal. In clinical phase 2 trials, so that is, it has been tested on humans. It is available in IV form and inhaled form. Already, IV has been approved in the US for multi-resistant infections, and now we have studies, particularly for patients with cystic fibrosis. And they are trying to have it in the inhaled form. Gallium is a heavy metal that resembles iron. And since the Pseudomonas uses iron in order for it to grow and proliferate, gallium replaces iron. The Pseudomonas believes that this is iron, and it absorbs it in order to use it, but it's not iron, and this leads to its destruction. So it's really useful for resisting Pseudomonas infections, and can be used in combination with typical antibiotics and act synergistically. Another molecule used is inhaled nitrogen oxide. These two in clinical phase 2 trials. Nitrogen oxide inhaled has a strong action, antimicrobial and anti-inflammatory action, and it is currently being studied in clinical phase 2 studies for atypical mycobacteria. It is considered to be breaking biomembranes, biofilms, and it will be in the inhaled form. The studies are quite good on that. And the last one is the phages. Many people are interested in that, from what I hear. The phages are not something new. These are viruses existing in the environment. In the early 20th century, before, in fact, we discovered antibiotics, there was the use of phages in clinical trials for patients suffering from several diseases. However, as soon as we started having the antibiotics, well, they were easier to use and they were of a broader spectrum. Therefore, we abandoned the phages for years. But nowadays, with the problems with resistance to antibiotics, they have been brought back on the scene, and they are in clinical trials, phase 1 and 2, for resistant Pseudomonas infections. But there are also studies pertaining to Staphylococcus. The resistant Staphylococcus is a big problem for cystic fibrosis. Phages dissolve the biomembranes as well, and they are going to be inhaled. The phages do pose many different advantages. First and foremost, they are not antibiotics. It's something we find in nature. It's reproducible. It's at a low cost. It's safe. There are not many side effects. And we need a small quantity. One phage is enough to kill a microbe, and they proliferate in the body because they are viruses. They are inhaled. They proliferate on their own, and they combat and they fight microbes. They have a very narrow therapeutic spectrum. In contrast to antibiotics, they act on specific microbes or even a subspecies of the specific bacterium. And this is both good and bad because there are no disorders and imbalances in our normal flora, but we need to know exactly which microbe we need to treat if we are to administer the proper phage. And we need to know this in advance, which is a problem for cystic fibrosis since we have multimicrobial infections there. And there's not just one microbe that we want to fight. Moreover, there are some theoretical indications. Since phages are viruses, they too interact with our immune system. Therefore, they might increase inflammation. There are some indications that if there is already an inflammation, which is really intense in cystic fibrosis, this might lead to the mutation of the phages, rendering them inactive, or this might lead to a further increase of inflammation because it's an infection. We inhale voluntarily a virus. Despite that, this doesn't seem to pose a significant problem. It's quite rare. So what we are currently trying to do is to prepare special phages mixtures in order for them to have a broader spectrum and be more efficient for our patients. For the time being, we have two mixtures going on in these studies. So the APPA02 mixture. In the lab, there was a successful result of 80%, and there's also BX004A, quite efficient, and it seems that they will move on and we'll find something for the resisting Staphylococcus. Thank you.
Πολύ ωραία, τελευταία σας διαφορά.
I really liked your last slide. Thank you, Mrs. Petrohilou. Mrs. Fotoulaki is okay with her connection, I think. Oh, great. Good morning, Mrs. Fotoulaki. Hello, how are you? I'm sorry for all these trouble. I'm very sorry I was unable to be with you today. There was an emergency that forced me to be away in Thessaloniki. I have faced some difficulties here. I'm trying to share my slides. Hope I will make it. Can you see my slides? We can see them all together, however. Yes.
Εντάξει, είμαι πολύ περήφανη.
I'm very proud. I mastered technology. I connected through a hotspot, finally. Let me thank the organizing committee. Mrs. Fotulaki, let me interrupt you. We are looking at all your slides. We should be looking only at the first one. Perhaps you should press F5. Wow, and I was so proud. Yes, we are seeing them, but we would like to see the first one. Okay, I pressed F5, but nothing happened. Okay, end of projection.
Να τις βάλω, πριν κάνω share, να τις βάλω όλες μαζί.
Before I share, well, it is the low right-hand button. Yes, when I press on this one. Stop the share screen.
Πίσω το share screen.
Ανοίξτε το να φαίνεται η πρώτη σε...
Open the first slide so that you can look at it. Yes. And do share screen now. I'm not looking. Where is the share screen now? I can't see it. Oh, it's not on the screen, the share screen.
Ναι. Okay. Την είχα κατεβάσει στο... Εδώ είναι. Όχι, λάθος. Επιφάνεια εργασίας θα πρέπει να πάω.
Ναι, αυτά έχουν οι ζωντανές συνδέσεις. Θα κάνουμε λίγη υπομονή.
This is what happens with live connections. Yes. Some technical instructions are conveyed to the speaker. We will resume interpretation as soon as she starts her presentation.
Ναι, αλλά έφυγα εντελώς εγώ από το Zoom τώρα. Περιμένετε. Θα ξαναμπω. Είχα κι άλλο Zoom.
Ωραία. Για να μην, επειδή έχουμε καθυστερήσει
Θέλετε
λίγο...
να προχωρήσετε?
We are lagging behind time. Could you do it without your power? Could you do your presentation without your PowerPoint? I have it in front of me. I can do it. Okay, you look at your slides and describe it to us, and we are just going to be listening to you without looking at the slides. This paper is about the effects of innovative treatments on nutrition and the digestive system. We have many signs in cystic fibrosis from the digestive, and they are related either to the digestive system itself, the pancreas, the liver, the small intestine, or They appear as a complication from other systems, as for instance, severe respiratory malfunctioning, which through mechanisms that we should not develop here, can lead to gastroesophageal regression or subnutrition. Of course, you cannot look at the slide, but the symptoms are not specific to cystic fibrosis digestive. It can be a range of systems, especially nutrition disorders. The main organs involved in these disorders are the pancreas, the liver, and the alimentary canal. Let us talk about pancreatic function in cystic fibrosis and its role in nutrition. We have talked about this so many times. We know that a large percentage of children, over 85%, has pancreatic failure. And this is reflected in digestion disorders in the uptake of nutrients. What happens with treatments, with the new treatments? It seems that pancreatic function can be restored to a very great percentage, up to 41%. According to a study, the mean children's age is 6 years old. Up to 41% of children with pancreatic failure had their pancreatic function restored, and the pancreatic secretions could lead to digestion and uptake of nutrients for an average time of 5 years. Let us keep this in mind because it's very important for the use of these agents from early in childhood. A further finding from the pancreas, we know very well that more than 15% of children with pancreatic sufficiency, some generation of enzymes, such that they are able to digest and uptake foods without an image of pancreatic failure and subnutrition. Of those, 20% suffer of relapse pancreatitis. Treatment in these children in acute pancreatitis is no different than the treatment of children without cystic fibrosis. And what studies have showed after the administration of the new modulators, it was found that their administration reduces the risk of relapsing acute pancreatitis. The result of relapsing acute pancreatitis was, in the end, pancreatic failure. So the administration of these drugs achieves these children preserve a sufficient pancreatic function. Another important role of the new drugs is their impact on the microbiota in the intestine. The microbiota is very significant, and it's very variable because of the antibiotics, because of disorders in the evacuation, the gastric evacuation, the modification of pH in the intestines because of the hydrogen pump inhibition. Many children have gastroesophageal regression. All these changes the microbiota, and it has been found that changes in the microbiota lead to increase of intestinal inflammation, and the increase in intestinal inflammation is associated with the gaining of weight. Furthermore, changes in the microbiota also lead to a change in the intestine-liver axis. the permeability is increased and inflammatory cytokines go to the liver through the blood circulation, and then we have an attack on the liver. The administration of these agents reduces inflammation, improving the microbiota. And as it seems from the reduce of calciprotectin, which is an indicator of intestinal inflammation. As to the liver, I was asked to speak more about the liver. Hopefully, in the little time I have at my disposal, I will be able to explain the role of these agents in the hepatic function. CFTR, as we know, is cholangiocytals in the fatty cells. Cystic fibrosis is characterized by hepatic attack. Hepatic attack is a general term, and it is different by hepatic disease due to cystic fibration, which is the hepatic attack is a general term, as I said. So the manifestations from the liver in cystic fibrosis patients is about the parenchyma or the the biliary system. And we have various symptoms and signs there. And also, we have to keep in mind that there are other factors like infections, pharmacological treatment, cardiac function also affect hepatic function. Equally important, in 70% of people with cystic fibrosis, we have hepatic steatosis to a very great extent, 70%. There are many factors that lead to hepatic steatosis that can use to hepatopathy, disorders to the enzymes, fibrosis that can lead to cirrhosis. Subnutrition in the past was the main finding. Now it seems to be obesity, together with other factors. The microbiota disorder. Espagan and Aspagan have defined clearly the conditions, the hepatopathy of cystic fibrosis due to CFTR. It's a multinodal cirrhosis without hypertension. There are various terms that are used. And some children do not have any hepatic attack. I used to have a very nice scheme that would show you how a disorder in CFTR protein in cholangiotic cells can lead to inflammation in the liver, or the microbiota disorder, dysbiosis in the intestine leads ultimately to the secretion of hepatotoxic cholic acids that are either absorbed by the blood circulation and damage the intestine, or precious cholic acids are lost, eliminated through the feces, or some factors are activated that increase fibrosis in the hepatic parenchyma, and all these factors together lead to these hepatic disorders that perhaps are not frequent. It's only 5 to 10% of the children that manifest hepatic disease due to cystic fibrosis. And until adolescence is the time where this hepatic attack is manifested. And later on, the percentage is stable. And there are no new manifestations in adult patients of hepatic disease. Of course, this is something relative. It is investigated, and it seems that even adults, young adults, might have it. It is a serious condition because it is the second cause for transplant, used to be until now, following lung transplant. Up to now, we gave Orsofang with many properties. We are not very enthusiastic today, as we used to be in the past, about this, because we have increased transaminases or increased gamma GT or a family in the ultrasound in the liver, according to our old definition. Today, in the era of new drugs, we see that these new drugs can be associated with transient increases of hepatic enzymes in a 5 or 10% of patients. But we don't see an exacerbation of the hepatic function despite their administration, if not in patients with pre-existing serious cirrhosis. So, we recommend these drugs in all patients unless they suffer from severe hepatic disease with hypertension. In some of these patients, there have been a colic has been described and recommendation for removal of the gallbladder after administering these triple 3-FTR treatment. But the encouraging thing is that the first studies showed that a combination of ribacaptron factor improves steatosis, reduces the need for cholic acids, improves hepatic function in children that have received 3 to 6 months after the administration of the combination. Rima factor affected the metabolism. It has interactions with other drugs, antifungal or contraceptives. It increases the hepatic enzymes, but this is transient. When these drugs are interrupted, hepatic function is restored. So it is recommended in the era of new agents to check for hepatic function every 3 months during the first year of treatment, with a temporary interruption of the drug in case of significant increases of transaminases. In the most recent studies, even in polymodular cirrhosis, we have seen a reduction of transaminases and other substances without a deterioration of hepatic function, reduction of bilirubin and other indicators, improvement of steatosis. But let us curb our enthusiasm, because a death was also identified in this triple combination with pre-existing cirrhosis. So we need to monitor cirrhosis, disease, very closely. It's not the ultrasound which is the golden treatment, but elastography. All these systems, disorders from the pancreas, the liver, and dysbiosis are frequent problems in cystic fibrosis, and they lead to nutritional disorders. So the main factors is the hepatic failure in absorbing nutrients. The sound was interrupted.
Με τη σύνδεση.
We have a problem with our connection. Well, thank you for what you told us so far.
We move on to our next speaker, Ms. Hadjiagorou Elpida from the Cystic Fibrosis Department at the Hippocrates Hospital. She's our last speaker for this panel, and she'll talk to us about what changes with innovative treatments. Good morning from me as well. Oh, we can't hear the speaker. Oh, now we can. Okay. I'd like to thank the association, in particular Anna, for having organized this whole session and event. And thank you also for the cooperation we've been having throughout the years. What's most important than everything is cooperation between doctors, between the association and the doctors, between the patients, the state, the doctors, and the association. So since you are really tired, and here, since we are running late, I'll skip some of the transparencies to share with you the most important messages. I'll start with some data from the American Registry of Cystic Fibrosis and data presented in the American conference, in the American Congress in Arizona, Phoenix. You all know that several microbes colonizing the respiratory system are these: Staphylococcus and Pseudomonas in green and in blue. So already Ms. Diamadea has shared from the American Registry the years, etc., since 1992 to 2022, the frequency and incidence, or the prevalence rather, of the respiratory pathogens. So Pseudomonas has been reducing, Staphylococcus is increasing, and you can see as soon as we had Ivacaftor and then the triple combination, that is the Trikafta combination, how all these influenced the prevalence of these pathogens. And again, with the pandemic, the fact that these patients did not come in contact with others, there was an even further reduction of these pathogens. Since we will be talking about how the triple combination affects our strategy as to the medication, inhaled antibiotics, whether we are going to continue without physiotherapy, how we can change things, still have pulmazan, the hypertonic solution of sodium, etc. All this is something that concerns the entire community for cystic fibrosis, and what in the States they've seen is yet another problem, in between quotes, which is a positive thing. Patients don't have big amounts of sputum, thanks to this triple combination. This means that we have fewer infections. However, we don't get enough samples for culture. So if we use pharyngeal smears, well, we know that they are not as reliable as sputum. So what we see as a reduction of the prevalence of Pseudomonas, is it 100% true, or is this due to the exam method? Now, there are here some measurements in the American registry, because they get more data as compared to the European and the Greek registries. And we see that the quantity of sputum by patients is much lower. So this affects also the way with which we isolate the microbes. So although we have a very positive element, we have reduced the prevalence of all these bad microbes, Pseudomonas and Staphylococcus. But on the other hand, it is the way we collect and sample that plays a part. This we keep in mind. So this is why in the States we have 2 studies in children under 6 and above 6 years of age, to see what's going on with infections and several parameters that pertain to the new treatment. The first findings from the PROMISE study. I don't stick to details here, but you can see how the prevalence of Pseudomonas is reduced through time. So therefore, we do have improvement in Pseudomonas concentration, but what are we going to do with the different inhaled antibiotics? These were data from the States. So respectively, we have the data from Europe, from the European Registry of Cystic Fibrosis, which is linked to the national one, the Greek one. We have collected data. We have 50,000 patients a higher number than the ones in the States. And we see what happens with respiratory infections and Pseudomonas. The countries, well, these colors show the socioeconomic level. We are ranking somewhere in the middle, in blue. And we see the prevalence of Pseudomonas in children up to 11 years of age, adolescents 12 to 17 years, and in adults. Higher rates of Pseudomonas in adults. Lower concentration in children, higher concentration in approximately 60% of adult patients. What is also impressive is that in the richer countries, we have lower concentration of Pseudomonas. So there's still a long way to go. Of course, we are not at the lower level, but we need to work on that. So what do we need to do vis-à-vis the triple combination and exacerbations? Do the data change? I'll skip all these slides. We know that in pulmonary exacerbations we have increased symptoms and reduced FEV. And it is important for us to deal effectively with exacerbations with IV antibiotics. I'll share with you what's new. So there was a partnership between the two adult centers and our own in Thessaloniki to see the first data. This was presented in the European conference, Ms. Manika, because it was her own idea. So we gathered the first patients who were on Kaftrio, 70 patients. They were the ones who were first, who had first access to Kaftrio, and they were more severe. The positive thing, well, the weight was increased significantly after Kaftrio. FEV1 significantly increased. Pseudomonas, statistically significant reduction. Respectively, reduction of the days on IV antibiotics and days in hospital. So there were many, many different benefits. These were the first patients. Now we have many more. What happened with compliance or adherence? We would tell them you will still go on Pulmozyme, etc., the inhaled antibiotics. But separately for each and every one of them, there was a significant reduction both in the use of inhaled antibiotics, Pulmozyme, and the sodium chloride one. How this will affect? Well, time will tell. Because we haven't seen how the respiratory function works. So patients don't have enough sputum, those on triple combination, but we are reluctant as to whether we can decide whether they're going to go on with inhaled antibiotics. So we might see that the culture is normal. Ms. Diamande showed a very nice transparency, showing us that the culture was negative, but the PCR was negative. So we need to be reluctant and be patient and try to adhere until more studies come up. The new studies ongoing in the States as to how we need to deal with pulmonary exacerbations. Because this is not something I'm telling you. The same concerns are for our colleagues in Europe and in the States. So 14 days good regarding the duration of IV treatment. Do we need to have aminoglycoside? Mr. Kumis said, well, no. So let us keep all that. Let's follow the guidelines. Let's be patient and stick to what the doctors tell us, even if we feel better, until we get some data. Another important part, physiotherapy. well, I don't have sputum, and therefore I don't need to undergo physiotherapy. Not only Greek patients say that, all patients say that. The tendency is to maintain physiotherapy as much as possible, but to replace it also with significant exercise, since we're doing better and our FEV1 is better. How will we respond to that? More systematic exercise, higher intensity exercise, because when I had the 30% FEV1, well, it wasn't easy. Now, with 50%, it's much better for me to exercise. I'll skip all the studies. It's a difficult time. But we see that there are many studies as to systematic exercise that can help us more. Last year's conference told us that the whole characteristics of cystic fibrosis change, and I think we can change it to the better utilizing the new drugs and treatments. Another thing, Mr. Lukides, in his address, said that there was this adults conference from the European Society for Cystic Fibrosis and the European Lung Society. So, they held this conference for adults with cystic fibrosis in Milan. This was also a virtual conference, and we presented data from the European registries of patients on adults. So what we've seen in the past 10 years in Europe, 19 countries, from 2011 to 2021. In green, we see the number of adults. It's increasing significantly. This is why we need to place emphasis on adult centers. Gradually, this will be a disease that will need to be treated in an organized way by regarding the adult population. What do we see in this 10 years period? FEV1, only in adults. Those were not lucky enough to be on the triple combination of Caftoro. A significant increase in FEV1. Prevalence of Pseudomonas, significant reduction over 10 years. We know that patients are malnourished. And here you can see on the right the percentage of underweight patients. There is a big reduction of underweight patients. This is important. And when you get data from such a large number of data, this goes to show how advanced we are in the treatment of the disease. The complications, pneumothorax, hemoptysis, these are significantly reduced, but in red we have diabetes mellitus due to cystic fibrosis. It is increased. Since we have an increase of the age limit, then we start seeing more problems with regard to adults' problems. So we start talking about obesity gradually. Now with exercise and Mediterranean diet will help us. This is going to be an adult's disease, and diabetes mellitus is going to be increased. And another thing to keep in mind, malignancy. The older the patients, the higher the incidence of malignancy. And I'll conclude here. In all these publications, we wouldn't have done it without you patients. What is important is that this is anonymous data. We can see how we can help and move on and render this a disease that will lead to the same life expectancy as with healthy people. And this is something that was published by the Ministry of Health. Basic data published for the first time from the National Registry of Patients with Cystic Fibrosis. This is our pride. This is the best registry in Greece. This is a role model for all registries. So it's important. What did we do here very quickly? We had the DPO licensing and authorization, etc. So we were able to share with you some basic data. It is available and on the internet. It was published by the Ministry of Health yesterday, only yesterday. And I'd like to extend to you a big thanks for giving us your data. Many thanks to the Ministry of Health, to the DPO, Mr. Zografopoulos, Ms. Mitru, the independent registry departments, and to the e-governance directorate that processes the data, checking the reliability of data. I'll share with you two figures, which we were glad to see, because we see how Europe, how Greece is faring compared to Europe. Because a few years ago, there were patients saying, well, maybe I need to leave the country to have a better future. So we see 54,000 patients in 2021. You can see the figures. So FEV1, percentage, corrects the speaker, of adults and children, the same in Greece and in Europe. FEV1, well, you can't read. 100% better in children. The BMI for children and the BMI for adults. Exact same data. We need to do some work on Pseudomonas. In children, we have same rates as in Europe. In adults, though, we have higher rates as compared to Europe. In the past, we used to have higher rates in Pseudomonas in children as well. So we don't need to discontinue the inhaled drugs. So a big thanks to all. Thank you. Thank you.
Ευχαριστούμε κύριε Χατζιαγόρου, ευχαριστούμε όλοι.
Thank you. Thank you all. Thanks to all doctors. I don't know if we have time for questions. We will not have a break. We will go directly to the transplant panel. And then during lunchtime, we will talk. I have hosts of questions, but I don't think there is enough time. Mrs. Fotoulaki, could I summarize my basic points because the connection was interrupted? You cannot see me now. It doesn't matter. What is important as to the administration of new treatments for digestive disorders, if we administer to children early on CFTR modulators, it seems that the pancreatic and the hepatic function can be preserved, which is very important. And something else I wanted to say, the risk of obesity is an existing risk. Already in 1999, 12% of children were obese or overweight, whereas in 2019 that was 32%. So 1/3 of children are overweight or obese. Already the alarm should be sounded. So at the same time with malnutrition, we have to deal with obesity. And this is purely through the administration with individualized diet, each child according to their need, we don't need hypercalorific solutions, and the Mediterranean diet should be adopted. These are messages that I'd like to send to you, as I did not have enough time earlier. Thank you very much, Mrs. Fotoulaki. We will move on to the next panel. I'd like to thank all the speakers who presented papers in this interesting panel. You can send your questions online, and the doctors will answer all your questions one by one. The interpreters wonder when will that happen. Mrs. Yanaki Konstantinou is the General Secretary of our association, will moderate the transplant panel. I invite the members of the panel to come here.
Να καλωσορίσουμε τον κύριο...
We'd like to welcome Mr. Tsagaris, who is a professor of pulmonology, who is at the Icon Athenon. He is responsible for the transplant center in the Onassion Center, and we'd like to thank him here for being here with us today. The transplants are really important for cystic fibrosis, for those who cannot benefit from the treatment. So, we are all ears, Doctor. First and foremost, I'd like to thank on behalf of the entire team for the invitation. It is indeed a great honor and a great joy to stand by you. We are always with you on a daily basis, and we consider it an honor to be able to participate in your struggle and fight. But as you can understand, sometimes things don't work as we wish, and we might need to move on to a transplant. Transplant in cystic fibrosis is a very frequent indication for, well, you can see here, cystic fibrosis is a very common indication. And these data reflect the situation before the advent of the new treatment that has radically changed the picture. There's a concern in the area to see as to whether we will have in the future referrals at a bigger age with much more complicated problems. So, if we are to have a good lung transplant program, we need to set this as a priority. Of course, it is your own priority. We understand this. Transplant activities in lung transplants in Greece counts more than 32 years. And I see that your association celebrates its 40th year. However, lung transplant is this transplant that is the most complicated of transplants. For this reason, many countries did not have their own transplants program. Even now in the Balkans, it's Greece, Slovenia, and Croatia who have transplant programs. As you know, throughout the previous decades, everyone would have to travel to Vienna. There was no other possibility. And thank God there was a significant number of patients who benefited from the operations in Vienna. You see that 70 or 80% of Greek patients who received transplants were young people with cystic fibrosis. But as of 2015, we knew that things would be different, and we had to have our own forces. So there was a Greek national program for lung transplants. This was not only the case for Greece, but for all European countries. So there was this program by the Onassis Foundation to train Greek doctors. There was this care by the states to create this program. And in fact, this initially started out by virtue of the government's gazette that you see here. The first transplants took place in 2020. Right now, we have performed 29 such transplants, of which 4 pertain to cystic fibrosis patients. So, lung transplant is a really difficult transplant. When colleagues from other organs see that the median survivals are such, they're always surprised. Cystic fibrosis, due to age, is an entity which has the best survival rates thanks to age of patients, but we can in no case claim that we are pleased with a 10-year survival rate. I'm talking about median survival rate globally. What is important and needs to be clear is that, well, this is from the heart transplant program. In fact, it's the same message. The right window. There's a specific golden window. Special practices need to refer patients with the consent of patients and associations. It is important. It's important for patients to go to the proper centers. Literature tells us when it's the most appropriate time for patients to be referred and to be included in the list. This plays a very important part if we are to improve the final outcome. Matching pertains to the size of the thorax and the blood group. This too should be taken into consideration in a country with a lower number of donors, such as Greece. And another thing that is pertinent is what you see here. In transplants, the donor age and the recipient age, as well as volume of the center, is really important. So, we will need your own help vis-à-vis the association. Who have been the donors? Athens Hospital and Nicosia Hospital have actually provided half of the number of lungs transplanted in Greece. You can see the contribution of all hospitals in this effort. Some definitely show that there's room for improvement, and this is the donors overall in Greece in the past 5 years. Why do I show you this slide? This all view that organ donation is not supported by society is absolutely wrong. What we've been able to show in Athens Hospital, it's at the poor neighborhoods of Athens, is that when there's a good organization, it's clear that the Greeks are in favor of organ donation, and rates are comparable to the European ones. So it's a system that needs to be improved. Now, this year we have 84 donors. You can understand that we won't be able to reach our peak figures in 2005, 2008, etc. But there seems to be improvement as of last year. There's been a great effort and significant action undertaken both by the state as well as by the Onassis Foundation and the new transplant center, the new legal framework. Everyone needs to coordinate if we are to improve this, because in fact what we see in this slide is the following. Every hospital can have donors. It's not the old perception that we're talking about car crash victims. 85% of donors come from patients being hospitalized in general hospitals. So to conclude with, all those heading the program are going to give us the details on the efforts that we're undertaking. And I'd like to thank you once again for the invitation, to wish you to be able to walk with us this difficult path, and I wish you nice holidays. Thank you.
Thank you very much, Mr. Tsagaris. We will now move on to the recording message of Mr. Chamogeorgakis. He is the director at the Cardiovascular Award. He is responsible for heart, lung transplant and mechanical support at the Onasios Center. Can we put on the video? Hello, thank you very much for the invitation from the Association of Cystic Fibrosis Greece. I salute the conference of the Pan-Hellenic Association of Cystic Fibrosis. My name is Themis Chamogeorgakis. I am a transplant surgeon. Recently, I returned to Greece recently. Lung transplants at the moment in Greece are underway. We have made a third effort to restart the program, and we've performed since 2020 at least 20 transplants, which include cystic fibrosis patients. 11 transplants overall last year. This year, 10. The forecasts will be 15 to 20. We would like to double the number of lung transplants and achieve better results. Survival, as you know, in transplanted lungs is not as good as with heart transplants. And every new program takes a lot of effort in order to yield good results. At the moment, we are 70% successful, and hopefully we will improve. In regard to technical matters, for a lung transplant, a double lung transplant in cystic fibrosis patients, it is the same more or less as with other patients. The differences for this category of patients is that they are usually younger, and this makes us more sensitive. It's at the limits of pediatric transplant, so the responsibility is even greater for transplanted children. Of course, the younger the patient, the more the reserves and the odds are better for a good prognosis, and we are happy about that. The organism is stronger. Despite the many infections suffered by cystic fibrosis patients. Another good thing is that there is a drug which delays transplant, because transplant is a last resort solution for a respiratory failure. Now, I'm coming to technical matters. Beyond the young age, things are more or less the same. If you can find a donor, if a donor is if an appropriate donor is identified, the appropriateness is judged on the basis of anthropometric elements, matching criteria between donor and receiver. There are two teams also, the harvest team and the team which is in communication with the donor and waits and places the transplant, the graft. The harvesting is carried out according to a specific technique. It's not relevant for this conference. I don't need to go into the technical details. The recipient is being prepared. The patient must be prepared by the team must be opened. The surgical incision must be carried out. The lungs have to be prepared in order to avoid wasting precious time. And as soon as the graft arrives, we can immediately proceed to removing the recipient's lung and graft the donor's lung. This is always by definition a double transplant. We cannot leave an infectious lung behind, so these patients are subject to double transplant. Lately, we have addressed some patients and they have done well. And don't forget the female patient who was in ECMO for 3 months or more. But despite the adverse conditions, she survived and she was released after a double transplant. One commentary for donors. The number of donors in Greece in the last couple of years was doubled, and this is due to the 7 coordinators who were placed in the big hospitals. They do a great job. We have now we receive many calls from possible donors. Hopefully, the same enthusiasm will go on in the future, and the Greek program will be a strong European program with good results and a big number of transplants. Thank you once again for the kind invitation, and I hope we will be able to communicate often. Goodbye.
Thank you very much, Mr. Chamogerakis. We move on to Mr. Thotheropoulos Fotis, who is the Registrar of Pulmonology at the National Transplant Center. Thank you. Yes, now you can hear me. Okay, excellent. Thank you. Thank you for the invitation. It's an honor for me to be attending your event to celebrate the 40 years of your association and to discuss about transplants. Thank you for voicing one hello of the specific topic. Although the probability is lower for a need of transplant, one might say that you might exchange one condition over another. I will disagree to that because we have with us here patients who have received transplants. So, I have quite a few transparencies and I will take more time. Now, lung transplant is a definite solution and the problem that unfortunately is not seen only on the lung, but we aim at changing the main organ that leads to a reduction of the life expectancy through a double lung transplant, which is the most indicated solution. We expect for the patient to reach 60 to 70% of everyone. The peak can be reached to the 6th or to 9th month. The second half of the year post-transplant, the patient won't have hyperoxygenemia and hypercapnia. These are quite frequent in malnourished patients with a poor performance status. Now, the transplant care. This is a very complicated mechanism. There needs to be a well-tuned Swiss watch in operation here. And even if we have a cog that's not working well, the whole system will fail. And time will tell. Here, of course, we have the patient coming in with the cooperation, the supportive environment, and other specialties. Be there in non-national hospital or in Atticon hospital, in care, etc. I won't refer to the role of each specialty. because this would oblige me to account for 50 or 60 different specialties. This is a government gazette showing how our program works, evaluation at our Attikon Hospital, the perioperative care at Onasion, and post-operative treatment in the first 6 months, again at the Onasion Center. And always in cooperation with Attikon, and there's a transition for the follow-up to Attikon Hospital. In Attikon Hospital follow-up, we also have Professor Jaks from Austria. 44 patients who had received transplants in Austria are alive and are followed up. Yes, 9.1 years, etc. It does not sound like a lot when we talk about median average. Median expectancy or survival. This is the example of a patient. Most of you know her. She is alive 21 years post-transplant, and I too am familiar with patients' cases in Germany who have survived more than 20 years, and there has also been a repeat transplant, and the patient is alive for the past 29 years. The patient is functional. She has never reached what was expected. FEV1 42%. She's working. She is moving, etc. She has this BOS disease, that is the chronic dysfunction of the operation of the transplant. A timeline of complications following transplant, lung transplant. Through time, the first 6 months, surgical problems, infections, either acquired at the hospital or in the unit, etc. Then we have cellular rejection, acute cellular rejection. This is this is seen like the end of life, but it's not so. The complications of the immediate post-operative care. In my view, knowledge is power. We should never underestimate patients. We should not deprive them of information that is important. Definitely targeted IV antibiotics on the basis of the antibiograms of both the donor as well as the recipient. If the recipient comes from a Greek ICU, we're talking about fungal antibiotics, etc., aspergillus. We'll have to provide double targeted treatment, inhaled and IV. High incidence of gastroparesis. This is to be expected. This is a side effect of medication. Gastric motility problems, difficulties in digestion, etc. Malabsorption. The patients are in high need of suppressive treatment, analgesics. DOS is an important problem that we should not underestimate, not only in patients with a positive history in the past, but even in patients without a history. We need to be cautious with regard to nutrition, and bronchoscopy plays an important part for the identification and timely diagnosis of all these three entities. Surgical problems, infections, and acute rejection. Regular bronchoscopies. Patients who have to receive transplants need to accept this. In the first 4 weeks, once or twice a week bronchoscopy, sedated, and then at regular intervals for surveillance to identify problems that might evolve and that will be incorrigible afterwards. there's a high rate of subacute acute rejections. This appears to be higher rate in cystic fibrosis patients. So one of them, or at least, will have one episode of acute rejection. This can be treated without leaving any residue. And of course, the identification of pathogens here. Acute cellular rejection might be non-specific. It might resemble simple infection with flu-like symptoms. We need to administer corticosteroids. You can see. And there's also the asthma monitor or the portable spirometer. Abroad, this is a must. All patients do it. In Greece, there's no such culture yet. We try to establish it. Several devices that are prescribed for cystic fibrosis. We can see the curve. The asthma monitor drops from 50 to 20%. Unfortunately, we were notified with a month delay. We acted, we administered cortisol, there was improvement, but you see that there is a falling tendency, which might be due to the delayed management. There was a chronic dysfunction installed afterwards. The longer the years, the more the patients tend to neglect the use of asthma monitor or spirometry. This is a problem. It has an impact on survival. There are many different studies, showing you one here. If we adhere to 80% of the instructions, we have a higher and better results. We talk about a regular and accurate administration of drugs, a nutrition plan, an exercise plan, preventive tests, and of course avoidance of smoking. I will refer to drug toxicity. This is really important. I like this study. This comes from Austria, with patients who might also be Greek patients who have received a lung transplant. Would you decide again for the transplant? 92% of them said yes. The main problem of these patients is the immunosuppression side effects. This is something that we cannot avoid. We need to avoid rejection, and we need to balance between rejection risk and infections. The characteristic example of the medications post-transplant. Tacrolimus. Nephrotoxicity, hypertension, hyperlipidemia, diabetes, trauma. Cellcept might lead to leukopenias, anorexia, gastritis. Of course, by changing and switching the medication, this can be improved, and teratogenic action in case of pregnancy. Cortisol, then known side effects and complications. How much time do I have left? 2 minutes. A very quick reference to the BOS and CLAD. We haven't improved greatly in the past 10 to 20 years. This is destiny, and we can't get rid of that. Well, we have a bit better results vis-a-vis chronic rejection, but in 5 years' time, 50% of patients will be in chronic rejection. Of course, the pulmonary function pertains to the patient, the comorbidities, etc. I refer to some factors that might lead to BOS. That could be colonization, the fact that Pseudomonas persists This might have to do with the reservoir if the upper respiratory tract that hasn't been taken care of as it should. Chronic rhinitis, sinusitis, this is not treated as it should. Moreover, gastroesophageal reflux. Now, CARV, I'm talking about community-acquired respiratory viruses, other viral infections that might affect the transplant. We need to know on time. The speaker speaks at extremely quick speeds. So each solution might stimulate a chronic or an acute rejection. All these factors are modifiable by the patient. What can we do? In the case of both, our hands are not tied. We can switch to Zithromax. We can have ECP, extracorporeal photopheresis. Already we have 4 patients at Attikon Hospital treated with very good results. Unfortunately, results show us that 15% of patients with BOS are already at stage 3. Very low function, under 15% of the baseline. This is a problem that can be solved with frequent visits to the doctors and with the asthma monitor that patients themselves check. If they wait to come to the hospital, you can see the condition in which they will reach the hospital. You can see what this ends with. ECP, etc., might lead to stabilization. Definitely there is a falling trend, but you can see the difference in the curve. The sooner we act, the better. We might be led to dyspnea and we might need palliative care or repeat transplant. Let me tell you a few things about malignancy. The second cause of mortality after rejection, skin melanoma, is much higher risk. You need to avoid the sun, good sun protection. Once a year you go to the dermatologist. It's better to prevent than to cure. Intestinal cancer, 8 times higher probability. A very good colonoscopy for screening, etc. We provide informative leaflets to our transplanted patients. Diabetes mellitus, 1/4 of patients suffer from that before the transplant, and the incidence rises up to 50%. We'll see how things go after the first 3 months of good regulation of sugar is important, well-regulated sugar and compliance. We opt for insulins and not metformin. Osteoporosis, 47% prevalence before transplant, 73% post-transplant. Timely diagnosis, substitution with vitamin Z, biphosphonates, and of course the renal failure. And I'd like to refer to psychiatric diseases as well. There's no special culture in Greek population vis-a-vis this path. Depression, stress disorders, very frequent. In the first post-op years, things go well, but as soon as the problems start, well, it's increased. Maybe medication is needed, supportive environment, follow-up by specialists, and the last slide, occupation or work. Many would ask me, can I work? What kind of job can I do? These are data from the International Registry. So in 5 years post-transplant, 40% of patients are not working, another 20% keeps on working. I could refer to Protestant views as described by Max Weber. In Germany, when you do something and you are offered something by society, the society needs to get get something back. Aside from that, which works in Germany, let me tell you that work is something that allows us to achieve self-fulfillment, allows us to feel productive, the feeling that we offer something, we move, etc. We support this. And of course, we can adjust to that. Thank you for your attention. To have access to the Hellenic Transplants Organization to donate your organs. So I think that this has helped us a lot. Thank you.
Ευχαριστούμε πάρα πολύ.
Thank you very much. Follow-up is very important. As important is the first step to the procedure, equally important is the follow-up. It is much more imperative compared to drugs and compliance prior to transplant. It is indicative. Patients' compliance is always context-related. A good management of the disease before is indicative of how it will happen afterwards. There are negative and positive examples, and we are often surprised. For instance, South European, Greek and Turkish examples were not complying enough. We are here to provide information. We need to explain. We need to go hand in hand. We are available 24 hours per day. Perfect. Now we give the floor to Manos Himonis. He is a coordinator of transplant at the Onasio Cardiosurgery. Well, before Manos takes the floor, I'd like to stress that we are fortunate because we started before the COVID pandemic. You realize what would have happened if our country had not a program during the COVID and people could not move. The dozens of patients would have been unable to move. It is already difficult for us due to our geographical situation. So the role of coordinators, the role of compliance is something that we need to stress to all of you. Lung transplant is not a mere surgery. It is a comprehensive package and we are all stakeholders. Manos will be coordinating all that. Good afternoon. Thank you for the invitation.
Ωραία, να πούμε όμως...
Okay, until your presentation comes up, I don't know, I can proceed. I have notes. What is the role of the coordinator? Transplant is the only treatment in a terminal organ failure. It is the only hope for survival and improvement of quality of life. The success of a transplant depends on the number of grafts and the willingness of society to donate. Without donors, there are no organs, and without organs, there are no transplants. Context: National Organization of Transplant Coordinator, the central coordinator, local coordinator, technical coordinator. The central coordinator, it provides competencies and duties to promote the national program, cooperates directly with local and clinical cooperators in organizing the procedure for a safe distribution of grafts, promotes donation through communication structures and programs, supports research, lifelong training and cooperation with abroad. Local coordinator is the link in between the organization for transplant and hospitals. Manages potential donors, approaches families, informs families about cerebral death and the possibility of donation, obtains consent, helps with harvesting, informs hospitals for the donation. Technical coordinator, projects, patients, controls and checks, puts in the recipient in the registry, monitors the recipient, mobilizes and organizes transplant process, trains and monitors the patient throughout their lives. The aim is it is a professional insurance of caregiving in all stages of the procedure. It is the link with patients, medical services, nursing services, and central services. Pre-transplant stage: admittance, planning, organization, tests, daily visits, control of results, information training, organizing the selection committee, informing patients for choices, waiting lists, entering recipients, 24-hour monitoring of patients, external coverage on a daily basis, transplant procedure, cooperation over the telephone, mobilization of team, organization of teams, organization of transport, control of materials, drugs. In case of inappropriateness, non-matching, interruption of the procedure. After the transplant, organization, admittance, results, information of patients about their clinical situation, drugs, treatments, monitoring through external clinics, interruption of drugs if thought necessary, and many others that the speaker is going over very fast. Thank you very much. For sure, what I retain, Mr. Tsagaris, is a hopeful message. We have grafts. We were under the impression that we didn't have grafts and that Greece was ranking very low in the list, but it's not like that. Well, listen, things are never black or white. Things are always gray. When you compare oneself to Belgium, which has the same population as Greece and performs 100 lung transplants per year, our 10 lung transplants may look like nothing, but our 10 transplants are many more than those performed in Romania and Bulgaria. So what one needs to look at is in what extent we as a system prioritizes resources. For instance, things like transplants need to receive the necessary resources. If you listen to what Manos said, you realize how many more resources we need in order to have things run smoothly, how resources should be given to a donation story. And there are all these cogs, as Fotis showed. As a society, we make an investment, 100 million in Onation only. If the remaining cogs are not working properly, this investment will be problematic. Therefore, there is a lot of work to be done by ourselves, by yourselves, so that in a competitive way, because the resources that we are claiming will be taken from somebody else. Unfortunately, this is how it is. We need to get the maximum resources, and with very strict accountability, these resources have to be put to good use. Any questions from the audience to our doctors? Mrs. Hadjiagoru. Questions should be to a microphone, otherwise you will not be getting the translation. Good day, congratulations. We're very glad with all this work that you have undertaken. We have experienced how things were before, and we have experienced how things are today. So we are filled with enthusiasm. What about pediatrics? Do we have any possibilities? What is the situation there? Well, look, there is a prediction so that the transplant center at Onation, and this is a priority. We organized a master class with all transplant units. This is a priority of the system. We have to cover pediatric cases in terms of lung transplant and in terms of heart transplant. There is a shortage there. As you know, young patients, in fact, are referred to Italy at the moment, with which we have a trans-border, transnational agreement. You understand that in order to build a program, this is not happening from one day to the next. It has to be built laboriously with a lot of organization. Professor Boletis, who is the locomotive of this effort in Greece, from what he presented, he has assigned priority to our transplant center at Onasio to cover these two significant priorities. To be honest, we are very enthusiastic about the new drugs, the new treatments, and we hope that a number of referrals will be really small. Well, the truth is that pediatric patients with cystic fibrosis will not need. But as pneumologists, we follow children with interstitial pulmonary disease. We have a patient of 4 years old who developed respiratory failure and is intubated to a respirator. It's very rare, unfortunately, but we have these cases with interstitial disease. Yes, they are very rare cases. We are monitoring supply throughout Europe. Pediatric grafts are very rare, and the pediatric community has to be involved a bit in donation. The good example of Attikon Hospital with adults is Iliadis in Patras. Athens and Thessaloniki need to be active with donations in order to have grafts. Without grafts, as Manos and Fotis said, of course, nothing will happen. You realize that the volume of transplants is strictly connected to the outcomes. This is true for all programs. The more things we do, the better we become, not only in surgical terms, but in the whole spectrum of management factors. And this is a social need. The little child that you say needs to have access to a good system. I totally agree. Thank you very much. Any other questions from the patients' organizations? Do we have a transplanted patient among us today? The photographs have just arrived.
Εγώ δεν έχω... Ήρθα στο πάνελ τελικά.
I came to the panel, finally. I don't have a question. I just wanted to say thank you, because we all know how difficult procedure a transplant is. From the beginning to the end, prior to the surgery, you have the pre-operational, the pre-op control, during, after. Thank you very much. Before transplants in Greece, our first priority was to secure this gift of life. We made a lot of efforts to sign the agreement with Vienna, and now that we do have transplants performed in Greece, we are here to provide every possible assistance. We also want to thank you, and we would like to thank the very brave people who, in the most difficult time of their lives, think about you, the families of the donors who truly donate life to many people at a very difficult moment for them. We are all grateful and thank them.
Να ευχαριστήσω και εγώ με τη σειρά μου όλους.
Let me also thank you all. Thank you for your participation. We will interrupt for lunch. You will have to go up the staircase, and there is also a stand with wares, products that you can buy for the association. Our association needs your support. We will have a half an hour break, and then we will present a book that our team has produced, a book for our young patients. Thank you.
On the outside, you might just see a happy child playing. A child excited to explore the world. You might not see a child with cystic fibrosis until you start to see its symptoms as they progress over time. But if you could see inside, you would see the damage taking place. Even before you see the symptoms progress and become visible on the outside. Don't wait to see cystic fibrosis.
We'll start with Mr. Tsokos Nicholas, who's online with us. I don't know if we have him. He has joined us. Good afternoon, Mr. Tsokos. Good afternoon. So he's going to talk to us about diabetes mellitus in cystic fibrosis. Good afternoon from me. Unfortunately, I was unable to attend because I'll be in another conference in Vienna. I tried to come early, but I have COVID and I was forced to stay in Vienna. So I'll be talking about the CFRD. You know more than me the problems of cystic fibrosis, respiratory tracts, lungs, heart, etc. But we'll be talking about pancreas and the liver. So diabetes is an extrapulmonary complication, and it's connected to increased mortality, morbidity. This is about the disorder of the metabolism of insulin. it is critical to know early enough the signs of the glucose metabolism. When we have early diagnosis and treatment, patients have a slower deterioration of lung function. The causes are not fully understood. It is a result of multifactorial conditions that constitute a combination. So we have maybe the destruction of pancreatic cells, alpha and beta cells, as well as the exocrine acinos. What are the repercussions? The diabetes has high incidence in patients with cystic fibrosis. The incidence increases through age, 2% for children, 90% for adolescents, and more than 50% in patients 30 and above. We can have multifactorial causes, functional and structural disorders that pertain to the transmembrane regulator and cystic fibrosis. This is expressed in beta cells of the pancreas. In animal models, we see that there is an inherent role to the secretion of insulin. We have mutations in CFTR gene that lead to an abnormal function of the beta cells. Now we see the membrane reducing the production of insulin from beta cells. The functional deficiency of beta cells might be due to the structural disorders. The mutation of HCFA protein intervenes in the normal operation of chlorium paths and channels, and we have pancreatic enzymes leading to autopeps of the digestion of the pancreas. And we have a progressive fibrosis, thus reducing the mass of the inlet cells. You can see the CFTR. It affects secretion. It causes beta cell dysfunction and the volume of beta cells, thus leading to insulin insufficiency and the cystic fibrosis related diabetes. Through pancreatic insufficiency, we have a malabsorption of fat, significant increase in signaling reduction, and insulin resistance. All this schematically is here. Now, the reduced production of insulin and glucagon is a result of the total destruction of the pancreatic islets. And this is an increased risk for CFD. Another scheme presenting the chlorium channels. Now, the clinical symptoms, polyuria and polydipsia, are not as often as frequent as in other forms of diabetes. It is impossible to maintain the correct weight regardless of the diet. We have retardation of growth and loss of weight, and we see this for years in children. BMI reduction is not necessarily seen because in the pediatric population with cystic fibrosis, the weight and the height are reduced together. So it is important for us to monitor the growth. The diagnosis, as in the rest of the diabetic patients, we have the glucose test, 75 grams, etc., or less in people with lower weight or in children. An annual check for CFRD should start at all children after the age of 10. You can see the solution, 75 grams of sugar per kilo of weight. We have blood drawn before drinking and 2 hours post. The measurement of urine glucose. We have the random sample of plasma for glucose and fructosamine, etc. All these are not recommended due to the low sensitivity. So we have glucose test. When do we have the diagnosis? When we have plasma glucose 2 hours post the administration of glucose above 200 mg per dl. Fasting glucose 126 and above. Glycosylated hemoglobin 6.5%. Random test of glucose more than 200 milligrams. The continuous glucose monitoring methods are really popular, so we've stopped talking about glucose values under 150, but we use the time in range should be on average 80 to 180. This is where we have best protection of the vessels and of the organs of diabetic patients. CFOD has similarities and differences with diabetes mellitus 1 and 2, but the pathophysiology is different. In type 1 diabetes, there's an acute onset, sudden onset. It could last some weeks. In CFRD, we have a gradual onset and it develops through years. In CFRD, there remains a small production of insulin, and cetoacidosis is quite unusual in CFRD, whereas in type 1 diabetes, it is quite frequent. So, differential diagnosis. What we have in the CFRD is that we don't have antibodies, whereas resistance to insulin in cystic fibrosis is in general transient due to acute presentation of the disease. Out of the complications of diabetes, that for diabetic patients type 1, type 2, we have diabetic retinopathy, vasculopathy, diabetic foot, etc. For CFRD patients, we have microvasculopathy, which is quite frequent, as well as the macrovascular complications that are quite rare. The treatment. We don't have many weapons in our armamentarium. Insulin, the basal or the prandial one. CFOD cannot get the best treatment without the perfect education, training, and the participation both of the patient and the family. Many times, because we do have a reduced glucose production by the liver at night, some insulins have the disadvantage. Detamid, for instance, lasts for 17 hours. We can administer it in the morning, and until 11 o'clock, the patient has insulin. After 11 o'clock, they don't have insulin, therefore they don't risk a hypoglycemia at night, because the neoglycogenesis is reduced at night. In the past few years, the best regulation is insulin pumps, continuous administration and CGM monitoring, and they administer insulin only when needed. We are talking about rapid onset of insulin every 5 to 10 minutes measurements. This can give us the insulin that we need. In cystic fibrosis diabetes, there is a whole team that should support the patient: the diabetologist, the pulmonologist, the dietitian, because you know that we need to regulate the diet because we need protein. We have a primary healthcare playing a part and a specialized nursing staff. So that's all from me. Thank you very much for your attention.
You know, diabetes is a problem for many patients, especially adults with cystic fibrosis. Can you remain in the panel for questions later or now? If questions could be raised now, please, to me. Any questions on diabetes that you would like to ask? Yes, we do have one question. Good afternoon, Mr. Tsokos. Good afternoon. Can patients with cystic fibrosis eat whatever they want, mainly sweets and candies? We adjust treatment to candies. We train them in equivalence. If you need 1 to 7, well, if there is a pump, it is okay. In children who do not have a pump, and there are many, at Sisma Noglio, which is the reference hospital, we have all children and we see them there. When they're dying for a sweet, they can. Insulin is a metabolic hormone. It regulates weight as well, so we can give it them. In patients with cystic fibrosis, is diabetes as serious as in persons who do not have cystic fibrosis? Diabetes induces microvascular complications, strokes, infarctions, limb damage. Yes, if it is long term and if it remains unregulated for a long time, it has the same adverse effects in patients with cystic fibrosis. Mr. Tsokos, now with the new drugs, the CFTR modulators, and I am one such example, we used to do insulin prior to these drugs, but once we started taking them, we stopped insulin. What do you have to say about that? Any advice? A lot of research has done with the act of the new drugs. Viscosity is reduced, flow is increased. In cystic fibrosis, there is generation of insulin at the pancreas. The issue is to have this insulin circulating in the body. So if the viscosity is reduced, then insulin can circulate in the body. I don't know if you need insulin. No, luckily I don't need it anymore, and I wish the same to many other patients. Thank you, Mr. Tsokos. Let us free you. Thank you. Take care. Let us move on to the next speaker who came from Thessaloniki to be with us, Mrs. Anagnostou Eftichia. She's an obstetrician, gynecologist. She teaches at the Aristotle University of Thessaloniki. She's going to talk about a very nice and pleasant topic. Now, with the new drugs, we can dream about making families. She's going to talk about fertility and pregnancy in cystic fibrosis. Thank you for coming.
Okay.
Let me thank in my turn for the very honorary invitation to come and celebrate your 14th anniversary. Your expression, dear Chairwoman, that I am the first gynecologist that you invited in such a conference because you didn't need advice from obstetricians. But now, with the new drugs, this is a very nice prospect. And this recalled feelings when I was a young doctor. I was responsible for the monitoring of high-risk pregnancy ward at the first clinic of Thessaloniki. We used to monitor women with such problems, but we knew nothing of cystic fibrosis. We had a young couple. The woman was the patient, the CF patient, and she asked whether she could become pregnant and if I could monitor her pregnancy. Uncharted waters for us, pregnancy in cystic fibrosis. The only thing we knew was the hereditary patterns. We knew that it was a gene disease with autosomal recessive succession type, and we knew the percentage of a child being born with the disease. That's all we knew. So what did I do? I mobilized my knowledge from monitoring high-risk pregnancies. Of course, the wish of the patient was very strong. She wanted to become a mother, and I had the conviction that all women have a right to motherhood under any circumstances whatsoever. I firmly believed that. So these two factors made me to accept monitoring her pregnancy in collaboration with many other disciplines, pneumologists, diabetologists, dietitians, and immunologists once she become pregnant. Now, look at the issues that a couple has to deal with, a couple who goes for consultation to a gynecologist, public or private. What they want to know is if their children will be healthy, if there is a way to do the prenatal control, what is the level of their fertility, and in case of pregnancy, what will be the evolution of this pregnancy for a female patient. As to genetic advice, first of all, now all couples who wish pregnancy are checked about the mutation of the allele which is responsible for 60% of mutations in cystic fibrosis. And the Greek Obstetrician Society had included this in the basic prenatal check long before Social Security funds reimbursed the cost. Now they all do. Further control is not reimbursed, and we're going to see what will happen with that. So if one of the two has the disease, if we have one healthy partner and one not healthy partner, all the babies will be healthy. If one is sick and the other a carrier, then they have a 50% chance of a sick child, 50% for a healthy child. If I have two carriers, then they should know that 25% is a diseased child, 25% a healthy child, 50% a healthy but carrier child, a carrier who is healthy. So how do we check embryos? There are these ways. If the pregnancy is from in vitro fertilization, there is the pre-implantation check. If it is natural conception, then the check is by receiving a trophoblast from the beginning of pregnancy and later on with amnio. As to fertility, let us start with males. Males are healthy as to their sexual lives, no problem whatsoever. However, the problem is that the thick mucus that is there obstructs ducts, and thus males suffer from azoospermia, which is obstructive. In a few words, testicles produce spermatozoa, but due to the obstruction, the spermatozoa do not go out with the final semen, and there is this subfertility. This reduced fertility. This can be solved with testicular biopsy and in vitro fertilization. Female patients, they have a totally normal cycle. They have normal ovaries, normal menstruation, normal hormones. Their inner and outer genitalia are normal. They have a normal sexual life. The problem is the thick mucus, which prevents spermatozoa from coming into the uterus and have the fertilization. A problem that can be dealt with injection of sperm, with sperm injection. And now the most important chapter, the course of pregnancy in cystic fibrosis women. It is a high-risk pregnancy. Don't delude us. Let us not delude ourselves. The respiratory health, the condition of respiratory health at the beginning of pregnancy is crucial. And of course, we need to have the agreement of the pneumologist. Most of the drugs that women take, drugs to liquefy mucus, inhaled antibiotics, the majority of those, and pancreatic enzymes and vitamins, women go on taking them at the beginning of pregnancy, and respiratory physiotherapy is possible throughout the pregnancy. In the first trimester, the pregnancy is the same as with every other woman. There will be no different complication, and the percentage of miscarriage is not greater in the first 3 months, but in the second and the third trimester, problems start to occur. The most serious are diabetes mellitus and respiratory infections. Diabetes mellitus, as my colleague said earlier, this is a condition that, in collaboration with diabetologists and dietitians, can be dealt with. The indications are the same. If insulin has to be administered, it will be administered, and they are followed just as any other woman with diabetes in pregnancy. What about respiratory infections? We give medicines, antibiotics, but what we want is, we want the infection to be treated, but we want them to be compatible with the development of the embryos, of the fetuses. Of course, in cooperation with pneumologists and according to the antibiotic charts. Sometimes we have had to administer antibiotics about which we would have misgivings. Of course, such antibiotics have been used. The impact on the fetuses was not different from what we expected. There has been no adverse event with the embryos or fetuses. And this due to the fact that they were administered in the third trimester. So the embryos were already big. Now, as regards labor in pregnant women with cystic fibrosis, it is not different with the other women. If they need to undergo a cesarean incision, they will. If not, they won't. The big issue is to have full-term pregnancies. This is the basic wager. Breastfeeding is allowed, and the puerperal period does not aggravate the disease. And I'd like to underline here the big therapeutical value of the new drugs, the modulators. that have been approved for administering from the onset of pregnancy and also during breastfeeding. In concluding, I'd like to share with you my experience from monitoring pregnancies of this sort. I monitored 5 women with cystic fibrosis, 6 pregnancies, and there were 6 healthy babies, 5 full term. 1 was premature, but it was a big premature baby, and it is healthy. I will admit that at first, apart from the medical problems I had to deal with, I had some problems that didn't have to do with medical parameters. There was a hesitancy in public and private bodies to manage this high-risk pregnancy because it was an unknown for them, and there was hesitancy among colleagues from other disciplines. Luckily, these problems were overcome. The wish of these women to become mothers was so big, and they had my support, moral, medical, psychological. The contribution of science has been huge with the discovery of the new drugs, the modulators. They have helped a lot. They acted as a catalyst for women to have good health, for pregnant women to come in good health. One of these women that I monitored throughout their pregnancies was 30 years old when she first came. 30 years ago, the new drugs were not around. She was in a good respiratory condition. She became pregnant through an assisted system, and she had a difficult pregnancy, many respiratory infections. However, in the end, she took a lot of drugs. I have to admit, I was very hesitant at the time. I was wondering how the embryo would go, but we didn't have another solution. That girl was born 12 years ago. She did all the tests. That's for the sake of history. She is 12 years old, very healthy, a good pupil. Also, 8 years later, the woman is taking the new drugs, and she became pregnant at the age of 39. A 39-year-old pregnancy is difficult per se without cystic fibration. She was receiving the new drug right from the start, and the only problem we had to deal with was an insulin-dependent diabetes without respiratory infections. The boy is now 3 years old. So we came to the era where we have the drugs, the prenatal control, a good monitoring of pregnancy and interdisciplinary approach, and all these help us to make the dream of motherhood come true in cystic fibrosis. Thank you.
Miss Anagnostou, very positive, whatever you shared with us. I think that we'll put questions right away. So you said this is the first time that we invite a gynecologist. Yes, indeed. In the past, things used to be really difficult. Just one question by me. Now, vis-a-vis the men, since many times there is a misunderstanding in male patients that they can't have children. Is this a difficult process for them? First and foremost, this is not true for everyone, this obstructive azoospermia. But if it is, it's not that difficult to handle. it is done usually in centers for artificial insemination, since indeed the spermatozoa and the testes are mature and are in very good condition, because we might have a biopsy of the testicles and being unable to find mature spermatozoa. But in cystic fibrosis male patients, these are mature. So there is a high number, and it is very easier to do artificial insemination, in vitro fertilization rather. I've talked to my colleagues, etc., in such centers, and they told me that there is no issue with the babies that come following this kind of assisted reproduction. So things go normally. What about the process? Is it difficult? Is it painful? No, it's not easy. It's a very small operation, a small intervention in the in vitro fertilization center, and it's done under sedation. Okay, we're talking about men, but women patients will have a longer way to go. Yes, because they don't only provide their genetic material, they have to carry the baby for a whole 40 weeks until they reach the end of the gestational period. Have you been with cases of women with low FEV1? None of the pregnancies came that simply. They were not that simple. At lower ages, etc., there were 2 women who had been randomly become pregnant. There was no one with a low FEV. So most of them had studied and considered it thoroughly. Yes, but despite that, in the era before the modulators, you know that there were many infections, respiratory infections, and we also had to handle the staff that was not familiar. I mean, I was really impressed by the way the transplant system has been organized. So the impression I got was why in pregnancies we don't have such a vertical unit, that we do it at the private level. And at our own personal responsibility. But this is something that is private, and we should have it in a public framework. We need to have vertical units, pulmonologists, gynecologists, neonatal department, a diabetologist, to have directly this cooperation without any delay. You know, most of you know that delays are the ones that will have a price to pay. Even more so in pregnancy, when we are dealing with 2 people. It's the mother and the baby and the child. So I think that this is what needs to be done. Yes, what you're saying is really important, and you are right to highlight it, because we too should organize as an association on that. You will be more and more who are going to be pregnant. Now, one last question regarding in vitro fertilization, since women are getting older, etc. What about in vitro fertilization? Can women undergo such a process if they suffer from cystic fibrosis? No difference whatsoever. It's as with all women, with the indications. Of course, they have a bit more indications from the point of view of cervical mucus. But personally, I've seen improvement in the quality of the mucus. As is the improvement in the nasal mucosa, then we see the improvement of the mucus in the cervix. This is how we have spontaneous pregnancies achieved. So there is no different indication vis-a-vis a woman who suffers from cystic fibrosis and is going through in vitro fertilization. There is no aggravation since the woman will be in a good respiratory status. It's as if healthy women were to undergo IVF. Of course, IVF has the option of the pre-implantation control and test, because some opt to have an IVF to have a pre-implantation test. If one is a carrier or two carriers, etc. In this case, we have the pre-implantation control. Let me explain what this is all about. When we have the union between the egg and the sperm, we get the embryo, and we send for tests to check whether this embryo suffers from cystic fibrosis, and is it a carrier or is it going to be a patient. And we get such an answer, so we know whether the embryo is healthy. And what we actually do is we transfer through the embryo transfer the healthy embryos, carriers included. Okay. Any question from the audience? Just wait to get the microphone. To what extent men with cystic fibrosis are fertile? Because I had read about 57 out of 100. Yes, this is about obstructive azoospermia. But I explained earlier. Despite that, I have 2 cases with a spontaneous pregnancy by a male patient. Really? Yes. Of course, the person most competent to talk about that is a urologist, but the way I see it, and the way I see the impact of modulators on the mucus, I suppose that they have a similar effect on sperm fluids. So therefore, the subfertility rates will drop. Without the modulators, yeah, I could think it's somewhere close to 97%. Despite that, let me tell you something. This is a very easy process, believe me. Is it under sedation? Yes, yes. It's a pity for one to stay behind for this reason. It's a big pity. My son is against it. He's against it, yeah. Well, okay. He's about to decide, and he'll make up his mind together with his companion, with his partner. Thank you. Regarding the carriers, is this true for carriers as well? No, no. I have 2 brothers, carriers, who did this, and this is a very simple procedure, and there was no correction. I don't think that there was any reason for that. I don't think that obstructive azoospermia was the reason for that. It was both my brothers who are carriers. But you'd have to tell us that it is a simple. Yes, it was really simple, and the problem was solved immediately. Off microphone, unfortunately, we can't hear.
Όχι ιδιαίτερη. Δεν υπάρχει κάποια τεκμήριο.
There is no scientific documentation regarding carriers on that. I'm reading that some studies say that some carriers might be presenting some symptoms of the disease in their respiratory system. Maybe this could be the case. Well, hello. My question is about cystic fibrosis women who have undergone transplant. What are their hopes of getting pregnant, and would that be recommendable? Yes, it is feasible. They can become pregnant either through assisted reproduction or spontaneously. The problem, well, we had uncharted waters in cystic fibrosis, and imagine what happens with the waters in women following a lung transplant. From my experience in the management of such pregnancies, the problem is the medication. But I heard in the earlier panel that there's medication that is teratogenic, but that may be replaced by some other drug. So if we have a very good preparation early enough in advance, that is, where is the assisted reproduction coming in? A lady who has undergone transplant cannot stay off medicine for quite some time. So what do we do? We discontinue this, or we have replaced this with another medicine, and we know that she'll become pregnant through assisted reproduction, either through ICSI or IVF. So we get the embryo and we transfer it. And I don't think that this is a utopia for a transplanted woman to give birth. It is feasible, provided that she will want it, because it's strenuous and it's quite risky because she's going to switch medications. But as I said, I think that everyone has a right to maternity, and we're here to support them. Thank you. Thank you. Other questions? Good afternoon. If there's a woman patient and the partner is a carrier, this pre-implantation control, how difficult is it? It's easy, but it is quite costly. It's IVF. Yes, it's IVF. It's IVF. You get the embryo from the first day, so we start checking the embryos, but there are some practical issues. The Greek law prohibits the control, the pre-implantation control, when one is under 40. But in the case of congenital diseases, this is allowed, this is permitted. In the case of a genetic disease, the pre-implantation control is reimbursed for ages under 40. In the case the lady mentioned, 50%. No, it should be 25%. No, one is suffering and one is a carrier. 50% they have a problem. Why am I calculating 75? Yeah, you calculate it again. You'll find the proper results. Miss Anagnost, I think that it would be really nice to have you here for another hour, but unfortunately time is pressing. Since I saw Mr. Theodoropoulos here and we talked about transplanted women, and we said that they are uncharted waters vis-a-vis pregnancy, etc. Is there any experience from abroad with women who have undergone transplants and have become pregnant? Yes, I had a personal experience. Unfortunately, there are data, depending on the gender, on the sex of the doctor who keeps track of the pregnancy. We have different results. Obviously, women pulmonologists show greater sensitivity and would recommend to their patients to become pregnant. Definitely 2 years post-transplant are a good period. There are 2 periods in pregnancy where you have a tolerance, etc. There are risks for rejection, and there needs to be a change in the immunosuppressive treatment. It is quite acceptable. Unfortunately, babies are low weight. There is a risk of prematurity. Antibiotics in case of infection is an issue. Yes, but I think that antibiotics are an issue for other women as well. I mean, there's no difference between the transplanted and the non-transplanted patients. However, there are cases who have successfully been able to give birth. Yes, yes, both pre-transplant and post-transplant. She did well, she gave birth, etc. However, I couldn't have a longer follow-up on her because I've left, it was a year ago. Yeah, I wouldn't discourage anyone. Of course, I wasn't able to attend the whole presentation. The surrogate mother is also an issue. I don't know what the legislative framework is in Greece. Yes. Yes, there is a provision regarding surrogacy, and since there is a genetic problem and there are opinions by doctors according to which women cannot tolerate pregnancy, the next option would be surrogacy. I think that this would be much safer for everyone, for us as well. I think that we do have a patient in Greece who has opted for surrogacy. Yes, she recently addressed herself to us, and we recommended that. But the financial part is an important obstacle. It is important, though, to start having something more organized vis-a-vis the pregnancy, because we'll start seeing pregnancies. And why not in transplanted patients as well? So this is why it's important to have communication and cooperation. Any last question for Ms. Anagnostou? Do you know whether there is a precedent from other diseases where the state would reimburse or cover a percentage of what? A percentage of the IVF? A percentage of the IVF? I don't think so. Aside from what I said regarding the pre-implantation check, a big percentage is covered by the state. I think 75% is covered by the state, is reimbursed. Well, the fact that you're going to have the IVF, well, means that you have the medication, the drugs, etc. Unless you do it on public body. In the private sector, it is what the prices are for everyone, with the exception of the pre-implantation test. What about this procedure for men to get the spermatozoa, etc.? Is this reimbursed by the state? Can this procedure take place in a public hospital? In theory, yes. But I think that it has to do with the organization. Yeah, it could be organized. Okay, thank you very much. Very interesting.
We will invite you again, but those of you who have more questions, you can meet her after the end of the conference. Let us go on to the next speaker, Mrs. Kousta Ekaterini, postgraduate physiotherapist at Papanikolaou Hospital in Thessaloniki. She will be with us online. Oh, we already have her. Welcome. Good afternoon. Thank you very much for the invitation. Sorry for the waiting. No problem. That everybody has to be functional because coughing and expectoration create a malfunctioning. So respiratory physiotherapy provides the solution for functionality and for a good daily routine. The aims of physiotherapy generally is improving pulmonary aeration, bronchial clearance, increase of reduced respiratory capacity, mobilization, and respiratory restoration. As you see, the goals of physiotherapy are the same as with normal people, as with non-cystic fibrosis people. Λοιπόν, first, body positioning, Fowler's position, breathing, active respiratory circle, exercise for breathing control, or independent drainage, forced expiration, positive pressure in air ducts, bronchial drainage with gravity and manipulation, and exercise of muscles. Autogenous drainage. Most patients do respiratory physiotherapy lifelong. So they have normal breaths executed in different levels, 3 seconds pause, and mobilization of secretions with airflow at expiration. In 2007, when I had my physiotherapy conference, or rather, prior to 2007, I'm sorry, but I don't have a good connection. There seems to have been a different approach in the past. Now they are trying to remove secretions with airflow. We don't want to combine physiotherapy with breathing fatigue. Patients should eliminate their secretions with no effort so that they can repeat these movements during the day. This is the active breathing circle. You can read it. We use cough when needed. This is sputum that arrives at your throat and you are ready to take it out. This is when you cough. Breathing control. Breathing control is a normal, calm breathing at the lower part of the thorax by relaxation of the upper level muscles. Expiration with half-closed lips. These techniques, the last two, can be used in case of dyspnea or feeling of not being able to breathe. The half-closed lips reduces the number of breaths and creates relaxation. Whether the previous things that I described was for expectoration. Forced expiration on various levels can mobilize secretions. During the technique, there is compression of the walls of the air ducts in the direction of airflow. This is to be used as a last resort when we feel that sputum is at our throat and it cannot go out. Forced expiration is never used when there is blood in the sputum. Bronchial drainage with gravity and manipulations. There are 6 to 12 positions, and gravity is used to move the mucus from small to big air ducts. The patient is placed in a lateral position. I have a very nice video all the techniques together. Then we have positive pressure devices, the a cappella, flutter, and cornet. Flatten is the most frequently used one because they can wash it, rinse it. And also when patients become of age, they may be tired and bored with respiratory physiotherapy. These devices are easy to use, they are perhaps more pleasant, and they give more options to patients. Or they can have a combination of physiotherapy and devices, or they can use the devices when they go on a trip, on an excursion, in order to expectorate without getting tired. Can you play the second video, please? This is the flutter. And age. And now we cannot tell what the speaker is saying. Physiotherapy. When? Why? Is it associated with pharmaceutical treatment? Is it associated with exercise? These are some of the questions that we can answer. Perhaps you can answer them. I will say a few things and then we can discuss them together. Okay, when? It starts as soon as the diagnosis and continues to the end of the patient's life. Why? In order for expectoration and for good respiratory function. What is the association with drugs? Should one precede the other? Usually the patient does the therapy, takes the treatment, waits for 20 minutes, does the physiotherapy, and then uses the inhaled antibiotics. Why because inhaled antibiotics have to enter a clean lung. There is a lot of literature, this is by way of indication, on the relationship between exercise and physiotherapy. I have always believed that we should first do respiratory physiotherapy and then exercise, because exercise will be facilitated in that way. Most patients don't want to do respiratory physiotherapy. They are tired. I understand them. They have to go through that year after year. So they don't want to do physiotherapy and they replace it with exercise. This is a mistake. They are totally different things. First, you have to do respiratory physiotherapy, eliminate the secretions, clear the lungs, and then you do the exercise. And if there is more sputum afterwards, so much the better. You eliminate that as well. Thank you very much. Any questions? Question. Well, I can wait for questions later. I don't mind. Thank you. There are no questions. So we move on with the next speaker.
Ms. Rakidzi Stavroula. Big thanks to Ms. Rakidzi, who is a volunteer psychologist and who has undertaken voluntarily the psychological support program run by the association in the past 2 years with very good results. She's going to present this to you, and we thank her for her volunteering for our patients. I'm the last one, so I'll try to be really, really brief. Volunteering in mental health experts is something that is self-evident. You don't need to thank me. This action is devoted and dedicated to all the members of the association and in memory of little Nicolas. We have stress disorders, depression, and fear of death in cystic fibrosis. Fear of death is not a mental disorder, but rather an existential reaction against something which is really difficult. So all scientists who have come here today before me and psychotherapy aim at reducing your vulnerability and at rendering you much more resilient vis-a-vis stress. The ultimate goal of psychotherapy is recovery and rehabilitation on the basis of the realistic data for each individual. There are two personal viewpoints. The recovery is a result. We measure the efficacy of our therapies, and the recovery as a procedure. You yourselves, you evaluate at all times, on a daily basis, on a monthly basis, on a yearly basis, your own course. And since you are the protagonists and not we scientists are obliged to help you and simply support you in the absence of the state, which does not support the health systems. So since you are the protagonists, I've called upon the members of these teams. I'd like to welcome Marilena here with her son. Stella with her family. Yanis, with the entire family, and Miss Athena, a grandmother who urgently came for the conference and who is really in a hurry to leave. So, cognitive behavioral psychotherapy is an effective therapy. There are many studies, and it examines the interaction between feeling, behavior, and thoughts. So we offer a group therapy that consists of 13 weekly 1-hour sessions. We have as a main goal to reduce the stress, to improve the mood, to empower and enhance skills, and we have an introduction into the management of grief. So we want to collect a sample in the coming years and be able to present to you a much more reliable result. But gradually we start seeing results. So we give questionnaires before and after. The patients group consisted of 14 members. 4 discontinued, 10 continued. The reasons of discontinuation: 3 were stressed, 1 declared that they were going to participate but never came. Group therapy is difficult, particularly when you have to be exposed online. Now, in the carers group, we had 16 members, 10 discontinued. There was a great difficulty by the carers to adjust to the rules of the team and commit for 13 sessions. We'll always be there, available, so those of you who want, you can come. So in fact, we have 6 members who completed and 5 who has sent questionnaires. So therefore, our samples are really small. Regarding the patients group, they have statistically significant results in stress reduction, in their ability to say no and place limits, recovery, and in the ability to do things that fill them with pleasure, as well as in their functionality. It is important in 13 sessions to be able to improve the functionality of patients. Also, it is quite usual for us social scientists to also check the effect sizes. The effect size is about how much psychotherapy has an impact on the several variables, and we have high effect sizes and an overall indicator of effectiveness, total therapy effect 0.57. In the carers group, we have a very small sample. However, we do have statistically significant results vis-a-vis depression and their ability to say no. And the effect sizes, well, moderate to high at all variables: depression, anger, functionality, etc., and total therapy effect 0.48, a very good one. Now, all these above results are correlated with a pilot implementation of 2022 and with international studies. Some of these persons were referred for individual psychotherapy because we are talking about an aggravation for many, the burden being too significant for many people. So then I referred them to the national health system, and these persons presented improvement. The aim of this intervention is training and education in managing a mechanism to deal with the daily life and to reframe life in order to enhance and strengthen individual responsibility, not only vis-a-vis the pharmacotherapy, the diets, etc., but also in the mental strengthening. The disadvantage of this specific year was that there was a big dropout of the carers and there was no comparison with a control group. I myself volunteer, but if we want to have a comparison with a control group, we need to find 2 more psychotherapists, volunteers. So psychotherapy is an indispensable part in the management of cystic fibrosis. We'll go on, and in parallel, I also ask the members, statistical analysis is our own job, and it is an objective data in order for doctors to understand how effective the treatment is. So the pediatricians say, okay, I'll send the parent to a group therapy. But what is also important is the impression of the members. So they told me I can think alternatively, I can be able to manage negative thoughts, I manage stress, anger. I improved empathy. We're not on our own. We are a family. This is the most important thing. If there's something that we stand to gain from these themes, is participation and this feeling of family. You do not feel ashamed to ask for help. You come to the groups, you commit for the sessions, and you ask for help. It is not a shame. Those who are burdened by health problems to have some mental burden. Thank you very much, and I will continue. I'll start with the cares because our dear Miss Athena, our granny, needs immediately. So you have the floor, Miss Athena. Good afternoon. So today I'm standing here. I've heard very optimistic messages from the experts that filled me with hope and relief. Now, we live as a family together with cystic fibrosis that I got to know as a disease with my grandchild, who is 2.5 years old today. As soon as we heard about the disease, I had negative feelings, fear, concern, insecurity, stress, all these negative feelings. It was darkness. Misinformation in the social media was horrendous. This was the first access I had. Trying to find some light, I got led to the association. It was a relief because I felt that I belonged to a broader family with the true meaning of the term family. I received messages and they allowed me to see some light. Then the association organized the psychological support sessions in which I stated that I would participate. And indeed, it was really important to get all this help as a mother and such a short notice from coming in contact with this disease. The framework was extremely supportive. Now, I think that this is different from psychological supports on an individual basis with a psychotherapist. I've experienced the group psychotherapy, and this allowed me to share, to listen what other fellow carers had been going through, and this gave me strength and courage. I think that it is really important for us as an association to try to go on with these group therapies because they're really helpful for members. I can vouch for that personally because together with all the therapeutic ways and methods, it's also this part. When you're on your own, we live in the countryside, and it is important for us, and it plays a therapeutic part to be part of such an effort. We do need that, and we thank you for whatever you have offered us so far, and I hope that we'll be able to have it also in the future, and if possible, I hope that it will be reimbursed and be provided by the state if we are to have such a support as carers. Not only for carers, but also for patients and for our own child who is 2.5 years old and still hasn't understood what it suffers from. Miss Athena, just tell us a few words about the future, because we don't have time, so others need to speak. Tell us what you think of the future. What I expect from the future is to have our young patient enter the triple combination therapy, to have as many procedures in Greece as possible. What we hear about gene therapy is what fills us with hope and allows us to see some light in the thoughts that come and go all the time. Thank you. Thank you.
Γιάννη, σειρά σου.
Yanis, it's your turn.
Γεια σας.
Good evening. I am John Veloudis. I'm husband to Anna, a cystic fibrosis patient. She's 42 years old. And we're very happy for that, because when you talk with someone, people hide years or don't accept the growing older. But in the case of a cystic fibrosis person, things are different. It is something happy. It is a victory to terminate another turn around the sun. But the truth is that nothing is given, and this is true for everybody, not just for patients. 3 years ago, Anna and I were almost permanently residing in Sysmanolio Hospital. Her health was very poor. She had to do IV treatments very often. At that time, there was this revolutionary treatment that freezes the tree catheter. We lived this with many struggles. The Hellenic Association on Cystic Fibrosis managed to bring this drug to Greece, and almost in 1 year, perhaps less, when according to the normal prospects as a new and expensive drug, were 5 or 6 years before it would come to Greece. That was a very big victory. Now, for the association and the struggle, the battle they waged and still wage, we should not forget whom it is comprised of. It is cystic fibrosis patients who work pro bono with a lot of cost for their health and a lot of time dedicated to that. I've always been around the board, and I know nothing is given. And this new treatment helped us to leave the hospital behind and come back to our lives. Anna is going for walks, she's driving a car, she goes traveling, she swims in the summer, and she makes plans for the future. It seems that with the strength of science, cystic fibrosis is beginning to lose ground. I feel confident that it will only become a medical history in the future, a medical history that was healed. Unfortunately, not all of our friends had the opportunity to take the new drug. We will always remember them. We just want to live many years in order to remember them. We will remember them fondly. In concluding, what I'd like us to keep in mind is that with patience, reason, and confidence and trust in medicine, everything is possible. Be strong, because the best is yet to come. Thank you.
Συγγνώμη εδώ. Κάθισε, όχι κάθισε. Και επειδή το θαύμα της επιστήμης...
The miracle of science is in front of you, Join, the husband of Anna.
Εγώ θέλω να πω ένα μεγάλο...
I'd like to thank Yannis personally, Yannis, John. We went through some difficult times. I wouldn't be alive unless I took this drug. I lived, and many others lived, and John has been next to me from the beginning to the end, and I'd like to thank him.
Κάποιοι από εσάς νιώθετε συγκίνηση.
Some of you feel emotional, but this is cystic fibrosis. There are many feelings involved. And now the floor goes to the patient. I have two historical figures. Stella, the relay goes to you. Stella's artwork is in Τζάνιο Νοσοκομείο. I hope you will always be healthy, Stella. 38 years old. I have been a patient for 36 years. I've gone through many stages. The first stages when it was considered an incurable disease. We were waiting for a drug. My doctor used to tell me it's coming, and it was not coming, and things like that. I didn't have time for the innovative treatments when they came around. When I was 18 years old, I had my first transplant in 2006. It didn't go well. I did a second transplant in 2014. Luckily, I am in a very good condition now. I can do things. I can do the things that I wasn't able to do when I was worse in the past. I am now studying, I can keep fit. I feel very different now. Of course, transplant is not a panacea. It opens new doors, it opens new horizons, but the problems are many and you have to be monitored. I can say that we are countering statistics which speak about 10 years of life expectancy. It is much more. I am transplanted since 2006. I'm 40 years old now, and I have more time in front of me. The question is, you need to have a will to live. But this is true even for those who are not patients. Everybody needs to be optimistic. We should not give up. Nobody should give up. Everybody should fight for the best, do things for themselves. My psychotherapy with Mrs. Rakidji was very helpful. She taught us to claim things that when I was in a poor condition, I didn't have the strength to claim, to fight for. I wasn't feeling self-confident. I wasn't believing in myself. I didn't have any self-esteem. This is a problem that you often find. In general, the association all these years has done a very constructive journey with the patients themselves. I believe that in Greece there are many things that can become better, a better organization with doctors, with centers, a better structured situation to avoid going from one doctor to the other and have everything put together at one place, and hopefully to have a treatment that will be appropriate for us who transplanted to solve not only the respiratory problems but also the pancreatic problems and all the rest. Because in essence we don't have only the cystic fibrosis problems, but we have the problems that are due to the transplant medication. Thank you.
Marilena, it's to you to whom we pass the torch. Good afternoon, everyone. A big thanks to our Stavroula, who psychologically supports us with her ever present interest, with many thanks to the doctors and to the nurses. Let me say a few words about me. My name is Marilena. I'm 56 years old and more, and I feel like all those women who many years ago had a predefined future where their parents would oblige them to marry someone. So this is how I saw cystic fibrosis. But to me, this was not a yoke, but rather a partner. I wasn't suppressed by it and oppressed, and it gave me incentives to do things that a patient with cystic fibrosis would never do. Most of the things I wanted to do have been done. There are other things in the list to keep on having incentives for the future. But what I want to say is that I had definitely been through many obstacles in my life, which I overcame thanks to my courage and stamina. I saw them as a challenge. I'd like to share with everyone that you need to look at the future with optimism, claim your rights, and do away with the selfishness. This is really erosive. I have nothing else to say. Keep the faith, have trust in yourself. Most things can become true and a reality. And I'd also like to call upon my son as proof that things can happen. It can become a reality. He's 27 years old, so everything can happen. Anything can happen. Concluding, I'd like to thank you. These 4 people said just one thing. The best way to deal with the fear of death is action for life. We all die. We all are born and die. We can't get away from death. But for some people, death is more specific. With the new treatments, cystic fibrosis, in cystic fibrosis, life is extended. So keep on living, keep on demonstrating this strength for life. Be well. Now, I saw that Marilena, Stella, etc. Marilena was the first patient in Greece, a patient with cystic fibrosis who became a mother, and she was the first president in our association. It was back then in 2000, the first time that we had adults patients in the board of the association. We've been through Estella. Estella has a first here. She is the first female patient in Greece who has undergone 2 lung transplants, and she's amongst us. She will continue to be amongst us for many, many years. I'd like to thank Stavroula Rakinzi for everything that she has offered. Indeed, we really needed the psychological support because we had left this behind. We were dealing with the medications, the treatment, etc. And we would forget about the basis of everything, mental health. Where are we to go with our mental health? So this was a big offer by Stavroula, and we're really glad that we're going to continue next year. And let me announce it that we are going to continue as of January. We'll have our new groups, carers and patients, as of January. So very soon you get the news as to when we will start, so that you can all participate and enjoy this big gift by Ms. Rakinzi. Konstantina, would you like to say something? I don't know, I'm really touched. I'm really emotional. There's always hope. This is what we keep. And all the testimonials of our friends show exactly this, that there's always hope, that anything can be done. And I will wish us all health. And a big thanks to my mother and my father for all these things that they have done for us. So we will conclude with this session. Thank you very much, Ms. Anagnostou, for having come from Thessaloniki next to us. I think that many of us patients will come to you, and we will have you next time. Ms. Rakinzi, thank you warmly for having come here, supporting our association. We thank the patients and the carers. Now we move on to our next and last session, the 40 years of celebration, 40 years of our Panhellenic Association. A very brief presentation by me, and then we'll hear Lana Denezaki and Ms. Petrochilou to show you our book. Please join me here on the panel, and I'll give you a very brief presentation. We can also watch our video. a very nice video. This was a video celebrating the 40 years, and we'd like to thank the person who is responsible for that, Dimitris Tsountarous, who created this video for free of charge, in a few hours' time. Thank you very much, Dimitris. So it's 40 years. We celebrate 40 years of our association. And in these 40 years, we have been able to change through our action the map of the disease in Greece in cooperation with our doctors and the state. And we are going to see what we've been able to manage. Before that, allow me to say a few words about our association. It consists of a board of directors. We are talking about volunteers, patients and carers and parents. And to the detriment of our personal time and without any remuneration, these people, these volunteers offer whatever they can. We have more than 1,000 members throughout Greece. We are talking about patients, parents, carers, relatives, friends, and we represent patients with cystic fibrosis throughout Greece. So we are in cooperation with the Scientific Committee of Cystic Fibrosis, our professional doctors specializing in the disease who provide us with their own advice. And of course, our association is a member and representing our country in European bodies, in CF Europe, in Eurordis, ELF, ERS, the ESOT, and of course members of other entities in Greece, the Rare Diseases Association in Greece, etc. The pillars of our actions, our priorities, support and empowerment of our community. We support our patients, their families, so that they can manage the disease and have better access to the provisions provided by the state. We try to strengthen and enhance specialized cystic fibrosis centers in order to have appropriate care for our patients. We try to improve access and timely access to medication and treatment. You've seen the fight we put up to have the gastro treatment brought in order for us to have it as soon as possible before it was even approved by the EMA. We support the actions for transplants. You know the actions. Before 2014 there was no access to transplants, and we had engaged into actions to have a cooperation with Austria. Then we had our own program, and you have heard about it and how well it's doing. Prevention is a very important part. We have raised the awareness of the public. We try to inform people who need to go through a prenatal test, timely diagnosis. Ms. Kanaka talked about it. We had neonatal screening in order for us to be able to see and diagnose cystic fibrosis patients, and through our campaigns we raise awareness, we inform the people that we are heard and people know about the disease. This is a picture we got at the documents of the association, a very old picture with Mr. Adam on a grey shirt. Mr. Katsouliaris was the first then president, the late Mr. Katsouliaris. So in 1983, some parents, together with Mr. Adam, created the association. They took the courage, they undertook initiative, and they established this association that allows us to be here and speak today. Very briefly, I have some milestones, what the association has achieved throughout the years. Since 1984, every year we have an informative conference. It is an opportunity for all parents and patients to meet, to hear doctors and learn more about the advances. Imagine the past where there was no internet, no social media, etc. It was important. We would wait for the conference, usually in winter, to listen to Mr. Dodonakis, etc. We would wait to see where we would stand. Now things are better. We have the social media, the internet, and we're able to have information. To cut a long story short, in 1996 we started screening on cystic fibrosis. We informed the state because they didn't know what the cystic fibrosis was all about. And parents managed back then to acknowledge as cystic fibrosis is a chronic disease and have a reduced contribution in drugs. In 1997, we became adults. We would grow, and we had an adults section at the Sismanoglion with Mr. Iglesias, and in 2012 the adults decided that we needed to speak up. We decided that we should not hide and not be afraid of speaking. So we had the first campaign, the Each Breath. We had the first patients on the first interview, television interview, speaking about their daily lives, how they live, etc. And then we move on to 2014 with interstate agreement, where we had lung transplants in an organized way to save patients who had to travel to Vienna. 2020, this was a really important milestone because we brought the treatment 3 years ago. We were able to get the treatment, early access program, etc., thus saving lives of patients who were in very dire situation. And we also had the National Registry for Cystic Fibrosis with many harsh and hard efforts. In 2021, there was the National Transplants Program initiation, and we started out our campaigns on transplants to raise awareness of the public to become organ donors. We had Lena at the Hospital of Nikia, and as of 2022, we established the psychosocial support program. Our teams are taken by Ms. Raketsi. The coffee breaks that we have on the internet providing support. We also prepared and established our site with a very analytical guide. Indeed, many have told us that the work that we have done, you see that there are all the government gazettes, etc. It took us months to do all this, but it's all there for you to see. And we continue throughout the years with the breath. Now, some of the actions, the programs that we had established for respiratory failure, conferences abroad, cooperation, Mr. Kikilias, then with the drug, etc., that we wanted to reduce, the spirometers that we give our patients. Here are some more actions that have to do with raising awareness. Bicycle races, concerts, etc. Vivian and Vasilis, who is no longer with us. We always love them, and these patients would start speaking in order to help us make our disease well known. And we also have the support of many officials here, the President of the Hellenic Republic, who supports our campaign. Always by our side we have institutional bodies. And nowadays, cystic fibrosis is recognizable. They won't ask you what this is about. They'll tell you, okay, I've heard of that. They might not know exactly what it is, but they've heard about it. This did not happen overnight. It took years of efforts. 2 more transparencies. Awards given to our association in 2016 regarding the campaign, the first campaign, Each Breath, And then we had in 2021 the awards for the mural that we had presented, the entire campaign for transplants. But we also got the Prix Gallian for Greece. We were awarded because we were able to bring the drug to Greece for early access. This year we have received the Bronze Healthcare Award, and we have a Humanizing Health Award. So it hasn't been announced yet, but only a few days ago I received it. We got we submitted a program whereby we are going to establish a helpline where patients or parents, etc., anyone now can call to get psychological support, and we let you know that this is a program that will be launched as well. So our objectives for the future, first and foremost, to empower the patients, our parents, to support them, the units for cystic fibrosis to be further developed, particularly for adults, because we have more and more adults, adult patients, prevention and information and awareness of the public, what it is. It's about cystic fibrosis, and of course access to treatment, the A to Z. Without access to treatment, we can't do anything. Any innovative treatment will see to it that we'll get immediate and direct access, as well as access to transplants for those of you who need it, who I hope are very few. So this was my last transparency. 40 years from yesterday to date, a huge path, a huge journey. We remember back in 1983, and we focus on the present and on the future, because what we need to think about is that our past is our legacy. We should not forget it, and on the basis of our legacy, move on forward. And give you also another optimistic message. We adult patients, 42 years old with cystic fibrosis, I'd like to say that we heard so many interesting presentations, hopeful presentations, etc., even by Miss Anagnost regarding pregnancy, etc. So our future is going to be even better. Those of you with small children have nothing to fear, indeed, because things will go better. The disease, well, my personal hope and wish is that, okay, it's a celebration of 40 years, and I hope that we will experience a moment where the association will no longer be needed. There will be no reason for its existence. So I think that this is the wish of all of us, to have a treatment that will put an end to cystic fibrosis.
With our fairy tale, a children's story, Secret Mission Cystic Fibrosis. Liana, because my voice is a bit rasp. Liana Venezaki is the author and the illustrator of the book. She dedicated her whole being to this book. So that they can read all the reverse writings in the book. There is also a pen so that they can write and read notes with it written with invisible ink. There is a card, a membership card for cystic fibrosis. And all these are gifts of the big children to the small children. Before explaining the purpose of this endeavor and talk to you about how the idea for this book was born, let me introduce the heroes to you. It is Chloe, a girl that was born with cystic fibrosis. She's worried that her parents are not telling her the whole truth about what is happening. I identified with Athena, who said that she was looking for information in the internet. and she was finding the wrong information. The same happened to Chloe. Chloe was looking for information about what was happening to her, and she found things that scared her, obsolete information or misinformation, which is something that often happens. As a result, in everything she reads and in the way she is informed from the internet, she gets scared, and this leads her to a denial. As a result, Chloe says no to everything, to all the things that can help her. And there you have Kiri, her pet cat. He wants to help her. Chloe says no to everything that can help her. Physiotherapy, drugs, proper taking of the drugs, exercise. She is a normal child reacting in the way a normal child reacts. Here are all those things that make her say no. Kiri, however, her pet cat, whose presence in the book, there is a first level, the obvious level. His purpose is to help her and introduce readers to the secret mission. But on a second level of reading, this may symbolize how much he cares about her. What the association cans, what they said in the beginning, that we are not alone in all that. We felt someone embracing us, hugging us. This embrace, this hug can be found, or rather is epitomized by Kiri. Kiri is with her in every stage of the book, even on the last page where Chloe participates in a big party. Kiri took his name from a tree, a rare species of tree, a very beautiful and impressive tree, whose main characteristic is that it is the tree that releases the largest amount of oxygen to the planet. To understand its strength, this tree daily binds almost 22 kilograms of carbon dioxide and releases daily 6. Specialists say that it is the answer to fighting the climate change. Kiri, however, also symbolizes a limitless breathing, what cystic fibrosis patients need. But not just they, the whole planet. There is a questionnaire by the Hellenic Association of Cystic Fibrosis to children and patients. The most frequent questions that children and patients with cystic fibrosis have is, why me? And this is answered in the book. When will I stop suffering from cystic fibrosis? I hope this is very soon. And everything shows that we will find a definitive treatment. And this answer should be answered by our young readers who, step by step, will unlock the secrets. Because when things go out to the light, away from the darkness, they become understood, and this understanding brings acceptance and the force, the strength to go over this obstacle, to fight this obstacle. Be that as it may, the aim of every reader is, together with Kiri, to convince Chloe. Every child is called to convert all the no's that she says to everything that can help her into a yes and why not? So this is a test that children need to solve the secret agents. On the basis of some information, they will have to search in this image. Just like Chloe, they were born with cystic fibrosis, but you will find out that this is impossible because no child with cystic fibrosis can be distinguished from all the other children. When we started this book, we all wanted not to create a character that would have to do something extraordinary to compensate for cystic fibration, to be champion, to save a village, to be apart from the other children. No. Chloe has a difficulty, like any child can have a difficulty, and writing this book for me was a fascinating experience, a journey. In this journey, I was not alone. From the first moment, a whole team worked together with me. They didn't just throw information at me. They were there in order to show that this transient ego is not there. There was always a togetherness, a we that created this book, which I wish will be a fellow traveler and will really motivate children to look for the team, to accept the no's, little or bigger ones, make them yeses in a journey to treatment. Personally, I would like to thank everybody who embraced me in this and made me a member of this team. I'd like to thank the scientific team of cystic fibrosis, personally, Mrs. Konstantina Giannaki, who, in all these endless Zooms that started with an 1-hour duration and went on until midnight, where she contributed with her brio and spirit. But Anna Spinu, also the president of the association, not only because she trusted me to illustrate and to write this book, which I repeat was a collective effort, for the story of the book seems to be a story coming from far back, not just from a memory. And I'd like to thank her for her passion, her inspiration, that gives strength to everybody and my own journey. I'd like to thank you very much. And should not limit anyone's life. Thank you very much from the heart.
Liana Tanezaki, σε ευχαριστούμε.
Thank you, Liana Tanezaki. It was a very beautiful presentation, and with no voice, you made it.
Αρχίσει, αλλά το κατάφερες και το
You did it all. You made it all by yourself. I will give the relay to Mrs. Petrohilou, who worked hard for this book. But before I do that, let me also say that this book was a dream we had. We've been having this dream for a very long time. It's not just something for the last months. We imagined how it would be if we, as young children, had such a book that would help us understand what cystic fibrosis is. So we want to give this to young children today, to give them a tool to understand. We didn't want a patient to do something extraordinary. It doesn't mean that because we suffer from cystic fibrosis, we have to become heroes and heroines. We don't have to go beyond ourselves. We don't have to prove anything to anyone. This is something that the old generation thought, and I think we should abandon this idea. We're ordinary people. This book will be distributed gratis to children, to caregivers, to anyone who would like to know something about the cystic fibrosis, together with the pouch. Our doctors will have copies to give to patients. And before giving the relay to Mrs. Petrohilou, I'd like to thank from the heart all the people who contributed, the board, Konstantina, Irini, Christos, Nadia, who gave their views about caregivers, about parents, our doctors, Mrs. Petrohilou. We stayed awake many nights, changing the book. Last but not least, Liana Venezaki. This is one of the best cooperations I've had in these 12 years in the association. It is the best project ever. It became a reality thanks to you. You are so remarkable. Thank you for embracing it with love. It was not just going through the motions, it was from the heart. That's why it came out so nicely.
Το έκανε όλο αυτό το μαζί.
It is all this embracing, all this together. Thank you. Thank you for everything.
Yes, Konstantina would like to take the floor, and then Ms. Petrohilou is going to close. Now it is my turn to thank my family. All this is done for Argyris, but they all help me to be here to help the association that's going to be helping Argyris. Argyris, together with his sister Triseviani and the whole family of Konstantina, were the ones who prepared the pouches, they placed the stamps and the books, etc., and undertook all this work that we see here today. They also helped with the writing. They were the first ones who tested the book, Argyris and Triseviani, and we thank them. Ms. Petrohilou, I think that we're all really touched. I think I speak on behalf of all healthcare professionals who saw this book and told us their opinion. And to us, this is a tool that will be helping for children, because children do have questions many a times. They want to know more about their disease. And we need to use terms that won't make them feel afraid. They will participate. And of course, it goes without saying that they will be afraid if they are not well explained. So thank you very much. This was a really interesting experience of the book, etc. I'd like to say this for Ms. Venezaki, because she immediately understood what cystic fibrosis is. And I was really impressed by the fact that she had understood very well, right from the first time, what we wanted. Thank you very much. Thank you. So I think that we gave much information to Liana, etc. I think that Ms. Petrohilou was so helping. Thank you warmly. Now, thank you very much. You can get the book upon leaving. Now, this concludes our conference today. We have concluded it. We thank all those who were with us here. We thank all those who joined us on the internet. We thank all those who supported us to hold such a hybrid conference. We'd like to thank Verdex Pharmaceuticals for their kind support for the book and for the conference. We wish you all Merry Christmas. You can enjoy. We hope that we won't be needing the association soon. Thank you.
On the outside, you might just see a happy child playing. A child excited to explore the world. You might not see a child with cystic fibrosis until you start to see its symptoms as they progress over time. But if you could see inside, you would see the damage taking place. Even before you see the symptoms progress and become visible on the outside. Don't wait to see cystic fibrosis.